you have already seen the current treatment options for IBD. The slides are not being projected. The current treatment options for IBD with mild to moderate ulcerative colitis, we have 5-ASAs, steroids and thiopurines. And for moderate to severe ulcerative colitis, mostly what we use is now referred to as advanced therapies and includes anti-TNFs, calcineurin inhibitors, anti-integrins, and JAK inhibitors and selective IL-12/23 inhibitors. These are now available. So these are collectively referred to as the advanced therapies, and the treatment approach could be a step-up approach or a top-down approach. We are all aware with this. And there is enough evidence to show that early use of advanced therapies over 5-ASAs, steroid or thiopurine is more and more favored, more so in Crohn's disease, but there is emerging evidence that in ulcerative colitis also, early use of advanced therapies improves outcomes, improves complete mucosal and histologic remission. So the treat to target, this concept you have already heard in the beginning. So in ulcerative colitis, in Crohn's disease, this is better defined in ulcerative colitis, which is the group which is fit for advanced therapy, age less than 40 years at diagnosis, any person with severe acute colitis requiring hospitalization, prior corticosteroid use, extensive ulcerative colitis, Mayo endoscopic subscore more 3 and UC-ESI score of more than 7, elevated CRP. So this is a very broad thing. If you look at it, the basic phenotypes, IV steroid resistant acute severe ulcerative colitis, steroid dependent ulcerative colitis, patients who are immunomodulators and not responding, and patients who are previously biological exposed. So these are the groups in which you are looking at more treatment options, and you heard Dr. Saroj, 30% is the usual response which you expect in these situations. So these are the different targets, and this is the timeline, and tofacitinib got approved in 2018 in ulcerative colitis. Now coming to tofacitinib, with this background we come to tofacitinib in particular. Tofacitinib is a JAK inhibitor. It's more on JAK1 and JAK3, and it has a lesser effect on JAK2. Now just giving a brief overview, what is JAK? JAK are intracellular receptors. This is a family of 4 intracellular receptors on which various ligands act, and this leads to activation of this downstream signaling of STAT, and this STAT dimerizes and moves into the nucleus where it activates various transcription factors, and that produces the different effects. And most of these effects are physiological and also play a role in the inflammation. So JAK activation is necessary for maintenance of many homeostatic functions and normal body functions. So coming to the pharmacological characteristics of tofa versus biologicals, what are the basic advantages? The basic advantage is that it is an oral drug. It achieves a very quick steady state plasma concentration, which is in nearly 24 to 48 hours. A very useful thing is that no dose adjustment is required for age, gender or body weight, so you don't have difficult calculations to do. Elimination of tofacitinib is rapid. Its half-life is nearly 3 hours. This leads to the advantages that when the drug needs to be stopped because of, say, adverse effects, someone gets pregnant, you can stop it rapidly, or someone is planning pregnancy, you can stop it rapidly. So the rapid onset and offset and therapeutic dose monitoring with tofacitinib is not required. So these are the advantages. So let me take you through this OCTAVE trials, which is the registration trial. There are a number of other trials also available. So this OCTAVE induction, there were 2 OCTAVE induction trials, OCTAVE 1 and OCTAVE 2, where 10 milligram induction dose was used for 8 weeks, and the responders were subsequently randomized to receive 10 milligram, 5 milligram or placebo. So this was 1:1:1 randomization. And this, after 8 weeks, if the patients who did not respond, they moved on to the OCTAVE open, and patients after completion of 52 weeks here in the OCTAVE sustain, they were then re-randomized depending on their remission into either tofa 5 milligram or tofa 10 milligram. So this is the basic scheme of these 3 set of trials, OCTAVE 1 and OCTAVE 2. These are 2 sets of induction trials, OCTAVE sustain trial, and then the subsequent OCTAVE open trial. So the primary endpoint in the OCTAVE induction and the OCTAVE sustain trial, in OCTAVE induction trial, it was 8-week remission, and this was significantly better than the placebo. In OCTAVE sustain trial, the remission rate both in the 5 milligram and 10 milligram was better than the placebo, and there was no significant difference in the 5 milligram and 10 milligram group. Mucosal healing was a secondary endpoint, and that was better again in the all the 3 trials, Octave Induction 1, 2 and Octave Sustain. This rapid improvement manifested by stool frequency and bleeding was rapid by day 3. Improvement in partial Mayo score was seen by week 2, and there was no difference in treatment outcome depending on the previous TNF exposure. Patients with prior TNF failures, the remission at 52 weeks was higher in the Octave Sustain trial to patients who were in TOFA 10 milligram versus TOFA 5 milligram. So patients who are in, this was a blinded trial. This is a post hoc analysis in patients in whom you start this tofacitinib. If the patients are exposed prior to biologic TNF inhibitors, they should be given 10 milligram twice a day. Now, these are the various post hoc analysis which has been there, and the most important one is to understand this Octave subgroups in which they were given extended induction. You saw that initial induction period was 8 weeks. So what happens if the person does not respond at 8 weeks? So the initial non-responders were given an additional 8 weeks of induction therapy, which was referred to as extended induction. And what was seen that after the extended induction, nearly 50% of patients who were given extended induction responded, and this led to overall 17% extra patients responding. So TOFA failure is basically defined as 16 weeks after you have used it for 16 weeks. So whenever you start using it, if the person does not respond to at 8 weeks, you can still continue it for 16 weeks. If the person is not responding at 16 weeks, then you are bound to stop it. Now, long-term response and when do you de-escalate? This is very important. So there are, again, these are post hoc analysis of these Octave 1, Octave 2 and Sustain trials. Patients who are in remission at 52 weeks, they were randomized to 5 milligram or 10 milligram, and this is the Octave open trial where till 3 years they have the endoscopic and histological data, and if you see the treatment response remains quite good. This is after the non-responder imputation. If you remove the non-responder imputation, that is the patients who are responding and who are follow-up, the response remains very good. So in simple terms, this can be understood as intention to treat trial or as the per protocol analysis. Again, riveting studies, again another this thing derived from this TOFA cohort only, where the patients were downstage to 5 milligram or 10 milligram. And again, TOFA 10 milligram has had a better response, and the predictors of response, long-term response, was a better endoscopic healing and patients who had prior TNF inhibitor failures. Now, recapturing the response. Again, this is a post hoc analysis of the main studies. What happens when you decrease the dose from 10 milligrams to 5 milligrams? If the patient relapses, you can recapture, and this can happen either in the consolidation phase, that is in the Octave Sustain, or in the post 52 weeks. Whenever you have a decrease in dose from 10 milligram to 5 milligram, there might be a loss of response, and this response will be recaptured mostly if we increase the dose from 5 to 10 milligram again. So this is again a chart which shows us how to use tofacitinib. We start with tofacitinib 10 milligram twice a day. Induction can go up to 16 weeks if it is not responding at 8 weeks. If there is response, we can reduce this dose to 5 milligram twice a day. If there is a flare, again, we can increase it to 10 milligram twice a day. If there is no response, then we need to stop this. If at 10 milligram, we are unable to recapture this response, then we have to stop it. At 16 milligram, there is no response, you have to stop the therapy. So, in essence, lowest effective dose needs to be maintained, to be given for maintaining the response. We should be considering the risk and benefit ratio. In case of loss of response, the dose can be escalated and the response can be recaptured. So this was in the study setting that we saw the response of tofacitinib. There are many real world trials, and there is a meta-analysis which shows equally good results with long-term this thing. Now, this was the setting in moderately severe active ulcerative colitis. Tofacitinib has been used in severe ulcerative colitis, and there are two studies. This TACO study, you all must be aware, and this is a gated cohort. This is a more difficult to treat cohort. Very briefly about this tofacitinib in acute ulcerative colitis. There's TACO studies from CMC Ludhiana. 104 patients were randomized. They were given either hydrocortisone plus tofa, and here the dose of tofa was 10 milligram thrice a day. And 51 patients received only hydrocortisone and placebo. The primary endpoint here was response to treatment at 7 days. In tofacitinib it was 83%, and in placebo it was 58%. So this was calculated on the LIT score. And secondary endpoint was the need of rescue therapy at 19 days, either in the form of colectomy or a use of TNF inhibitor, and that was better with tofa. So there is enough proof, and this is a very useful thing where you can use it because of its rapid onset of action in acute severe ulcerative colitis also. So looking at the use of tofacitinib in special population, in pregnancy it has not to be used because it has the potential to cross the placenta. There are teratogenic effects, and it is not approved in the treatment of pregnant and breastfeeding women. In fact, anybody who is planning conception, you should stop tofa at least 4 weeks earlier before you start it. Pediatric population, very little data. Adults, again, used with caution. You heard this earlier. Now, what is the safety of tofacitinib? This is the very important question. The initial apprehension was from the rheumatoid arthritis studies where higher doses have been used. However, in the Octave 1, Octave 2 and Octave sustained trials, the side effects, the serious adverse events are comparable to the placebo, and there is no difficult signals. And eco standpoint on JAK inhibitors is that patients with ulcerative colitis, they are younger, more often have less comorbidities, they are less smoking in these patients, so the risk of these thromboembolic complications are less. Again, the long-term side effects in Octave open, herpes zoster, deep vein thrombosis and pulmonary embolism, these are the important things which we are concerned. So looking at some of these complications, herpes zoster, JAK inhibitors are associated with higher incidence of herpes zoster. This is dependent on their mechanism of action. And the newer drugs which have which block the different receptors, this incidence of herpes zoster will be less. The risk factors are age more than 50, prior exposure to biologicals or failure to respond to biologicals. However, the clinical course in most of these patients, more than 90% patients, is mild, and you can continue tofacitinib in most of these patients. Recombinant vaccine is available which can be given on therapy. You don't need to use live vaccine which cannot be given on therapy, and the ACG guidelines recommend to vaccinate anybody who is more than 50 and anybody who is started on immunosuppressive therapy. Lipid profiles, again, the maximum lipid levels are reached within 6 weeks. They have to be treated according to the standard guidelines. Thromboembolic risk, again, all the studies, there has been an alarm, but these patients are older, have other risk factors, so practically the risk is quite low. Tuberculosis, again, in the from the rheumatology data which we have, the ACR guidelines, the rheumatology guidelines suggest that pre-tofacitinib, these patients should be screened as we screen the patients with TNF inhibitors. And in Indian scenario, although there are no guidelines, we should screen these patients as we screen them before TNF blockers. So practically, if we want to start tofa in a patient, these are the baseline tests which we need to do. These are the recommended vaccinations. This is a long list, but practically some of them are already done and some of them we should be doing. On treatment monitoring, they should be monitored regularly with hemogram 4 to 8 weekly. Since JAK2 is involved in hematopoiesis, you will need to monitor this more closely, and if the hemoglobin is falling down or if lymphocyte count is low, you need to stop or modify the dose. Lipid profile, you should be doing 4 to 8 weekly or 6 monthly. LFTs should be monitored, and cirrhosis, child A, you can use it in normal doses. Child B, there should be a dose reduction, and child C, it has not been used. In kidney function test, if the creatinine clearance is less than 30, you use it at a dose of 5 milligram per day. There are various guidelines. Now, these are the ACG guidelines, 2020 ACG guidelines, AGA guidelines, which recommend the use of tofacitinib along with this TNF blockers, the anti-integrins and IL-12-23 in the patients who have not been prior treated but only in the research setting. And this is a very important thing, that patients who are TNF failures, especially infliximab failures, instead of going to vedolizumab, it has preferred tofacitinib or tofacitinib over vedolizumab. ECO guidelines again incorporate them in their guidelines, maintain the induction or maintenance of moderate to severe ulcerative colitis. To summarize, these are the small, tofa is a small oral molecule with the benefit is rapid onset of action, good safety profile, moderate to severe ulcerative colitis which are steroid or immunomodulator dependent or resistant. Now, do we use them ahead of TNF blockers or anti-integrins? That is open to question. Acute severe colitis, severe ulcerative colitis, there is some data of using them. Contraindicated in pregnancy and used with caution in pediatric and elderly group. Thank you so much.
Thank you, sir. Now it is open for discussion to the House.
What is dosage of tofacitinib? Somewhere it is written 10 milligrams, somewhere it is written 11 milligrams. I can't understand what is the difference between 10 milligrams and 11 milligrams.
So that is for the ease of use. If you are using 5 milligram twice a day, instead that is from the rheumatology practice which you get that 11 milligram dose. So basically for ulcerative colitis, you use a 5 milligram or a 10 milligram twice a day for time.
Nice talk, sir. Sir, where?
Second question is tofacitinib going to replace 5-ASA?
5-ASA, sir, tofacitinib and 5-ASA are going to be in different settings. If the patient has got mild ulcerative colitis, is maintained on 5-ASA, you don't need to use tofacitinib. The question is that whether you use it ahead of azathioprine in patients for maintaining the remission. So that is going to be the question, and maybe yes, there is some indication that it can be used, and the benefit here is that it can be used in acute setting. It has got a rapid onset of action. Dr. Saroj earlier mentioned azathioprine takes time to act. You cannot use azathioprine to induce remission. Here you can use it both to induce remission and then to maintain the remission. And the monitoring probably is...
The concept is changing treat to target.
Definitely, sir.
Not treat to symptoms. And tofacitinib treat to target. And ASA treat symptoms.
No, targets are different things. The targets are unique. I mean, targets are the treatment targets are symptoms. The treatment targets are biomarkers. The treatment targets are endoscopic remission. So these three are the targets which are different. In the STRIDE, Dr. Sinha also mentioned in his talk that STRIDE gives you these three or four this thing for monitoring it. Like you treat blood pressure, you need blood pressure monitoring. You treat sugar, you need HbA1c monitoring.
I think Dr. Ramesh is leading us to a dark area, which is gap area of information as of now. That if somebody goes into remission, whether you continue with only tofa or tofa with 5-ASA. In India, most of the center as of now. So whatever you are giving azathioprine, you continue with the 5-ASA because of chemo preventive effect or benefit in terms of reduced risk of colonic malignancy. So as of now, even in the world literature, this is a gap area, and this has been repeatedly discussed. This happens with tofa, this also happens with EJA, and this also happens with anti-TNF alpha drugs. So we expect there are multiple trials, including some trial at our center we are conducting. So that after induction of remission, whether we discontinue 5-ASA completely and maintain only with either immunomodulator, either with azathioprine or induce with tofacitinib or whichever agent, and we continue with that and do away completely with 5-ASA. As of now, clear information is not available. The problem in this strategy is different. Like you cannot make a blanket statement. Somebody who is responding to one agent can flare, and then what will you do? You will add 5-ASA or not? And then if you say for it, tomorrow information comes that okay, induction induced by tofa, and then you continue with tofa and do away with 5-ASA. That may be all right, but whether you will apply the same information to EJA, possibly no. Because what happens that induction by which agent you has achieved remission, it says that this particular disease in this particular patient is responsive to particular therapy. So that is basically raises the question of customized therapy, for which as that itself is a gap area as of now. In my talk I showed you that you do genomics and then you decide on treatment. So as of now your question to your answer is possibly not available in literature, but we do expect that in coming few years time we will have the answer.
So in these Octave, what Sir has answered, that is a different aspect of the same problem, that in Octave studies, the drugs which were allowed, 5-ASA was the drug which you could continue even if you were giving tofacitinib. And the long-term chemopreventive action benefit of 5-ASA has been proven. And in future, if the patient is in deep remission, you are considering an exit strategy, then you will have again to fall back on 5-ASA probably. So Sir is right in that way. So if a patient is in deep remission for 3 years, 5 years, and you want to discontinue tofacitinib, you cannot discontinue therapy altogether. So probably 5-ASA will come handy at that time.
So to add to that, in Octave they tapered down the steroid, only continued with 5-ASA, I think. The patient who were in steroid in both 5-ASA. 5-ASA are maintained. But
no, in this again,
steroid
in Octave, 20 milligram, 25 milligram, this thing was permitted at the onset. Patients who were at a dose higher than 25 milligrams were not included in Octave induction studies. And steroid could be continued. I did not show that result. Around 30% patients were still on steroid in Octave sustain at the end of 52 weeks of therapy. So steroid-free remission was better, but again there was a subgroup of patients who were both on steroid and tofacitinib at 52 weeks.
okay. So my question is where to place tofa in the management of acute severe ulcerative colitis? To begin with the steroid, like Dr. Sood's group had shown, or between biologics and steroid, or can it be used with biologics also?
Combining biologics and tofacitinib in acute severe ulcerative colitis, that is still no data. And Dr. Sinha again, he mentioned about combination therapies. These are patients in whom you fail to maintain remission. Probably they will be the candidates of having dual therapies. In acute severe ulcerative colitis, the standard still remains steroids. You go with steroid, look at your response at 7 days, 3 days, 7 days, and then you have option of either moving on to TNF blockers or moving on to tofacitinib. Now, starting steroid and tofacitinib together, again, this has to be done in a study setting. There has been one study. You need more data before it becomes a routine practice and a recommendation.
Why tofacitinib is not effective in
Dr. Sinha will answer that question.
tofacitinib poly-JAK inhibitor, pan-JAK inhibitor.
These are probably due to the cytokines which are driving the inflammation in the ulcerative colitis. The inflammation is driven more by these.
So you have upadacitinib on the horizon, and that upadacitinib has shown efficacy, and possibly that is on the top of the list. So maybe in the next few months' time, you will not have to make a distinction whether this is IBD UC or it is Crohn's colitis, and then you can blanket, you can go for upadacitinib. I got up to answer another issue. Like somebody is asking about the use of tofacitinib. The acute severe UC situation is where you are talking in terms of hours, not even in terms of days, because you talk of 42-hour response, or 48-hour response, or 72-hour response. So that much time you want to give the drug to have the efficacy. Most of the drug don't have so much of rapid onset of action. So tofa is one drug which has rapid onset of action, but if you see the most rapid onset of action is still infliximab. Even adalimumab and risankizumab doesn't come so close to it. So in that is the typical scenario where you want very rapid onset. So only tofa as a first line, I don't see it is coming. As a rescue might come with some caveat, but as combination, already you have TACOS trial where they have used in combination, and that has improved the efficacy of steroid. So that is the main problem I tell you. tomorrow you will have some other biologic which has very quick onset of action, then possibly that will come in the forefront.
Thank you, sir, for your nice elaborative lecture.
Thank you, sir. I would now request our chairpersons to kindly felicitate our speakers, Dr. Piyush Ranjan, sir, our previous speakers, Dr. Ashok Chaudhary, sir, Dr. Manoj Kumar Badani, sir, Dr. Saurabh Jaiswal, sir, and Dr. Sanjeev Jha, sir. I would now request our chairperson, Dr. Professor Binde Kumar, sir, to kindly felicitate our other chairpersons. I request Dr. Jain Kumar Ghosh, sir, to kindly felicitate Dr. Professor Binde Kumar, sir. Thank you, sir. Now I request all our speakers and our delegates to kindly proceed for the lunch. In the meanwhile, we will also be having our event of poster presentation at the VIP lounge. I would request you all to proceed for the lunch. We will meet again sharp at 2:30 p.m. for the next sessions.
questions from the audience so that we can finish it on time. So to start with, chairpersons for the next session are Dr. B.K. Agarwal sir, Dr. Manoj Sahu sir, Dr. Ramesh Chandra sir, and Dr. Rakesh Kumar sir. Please come on the stage. And speaker will be Dr. Saroj Khan sir. Sir will be talking about rationale of acid suppression therapy, which is exactly needed at this moment.
Thanks to Dr. Manohar for giving me opportunity to be here. He is talking about the less questions for the audience. My job is simple, to ensure that everybody goes to sleep from the boring, so there will not be any questions. But unlike my previous talk, which was slightly looking into future, so not everybody must have been comfortable. This is into hardcore into reality, and almost all of us must have prescribed BPIs or used acid suppressor in thousands or possibly lakhs of patients. And we all tend to believe that we all know all the nitty-gritty of acid suppression. But still there needs to be learned on finer points, and I will try to discuss some of those. So if we see acid suppression, obviously acid is secreted by parietal cell, and there is a pump called sodium hydrogen or hydrogen potassium pump through which it gets secreted. And this is the diagrammatic presentation. The important point, there are lots of modulator which are located in different portions of that. And interestingly, the hydrogen potassium pump in downstream, so when you block hydrogen potassium pump, all those modulators become ineffective. This is in contrast to H2 receptor blockers, which blocks much proximally, and so those modulators still will be effective. So this works on the final common pathway. So that makes sense that if we want acid suppression, that will be practically foolproof. So that most of those cells are located in the neck region of the gland. So that is from where, and that is inherently linked with the secretion of intrinsic factor. So whenever we go for acid suppression, intrinsic factor secretion also decreases. So that needs to be understood. So these are the current indications for acid suppression in the short term. So all of you are aware, I am not going to discuss, but newer indications are emerging like post-ESD, post-EMR, or post-EMR. That is also indication for acid suppression now. And this is the long-term use, and at the bottom you saw antiplatelet therapy in high-risk patient. There also the acid suppression is indicated as of now. So acid suppression by PPI, there is certain caveats. I said that it inhibits hydrogen potassium pump. So that is the most downstream step in the pathway of acid secretion. So that is that we overcome or working downstream of all the modulator pathway. So that is the final pathway. So it is very effective. But the caveat pumps are of two types: active pumps and passive pumps. Active pumps are what? They are secreting acid. And hydrogen potassium pumps are interesting things. They secrete either acid at the full pace or they don't secrete at all. So what happens that how the acid secretion in the stomach varies. This is based on the number of pumps which are recruited. So at a given point, the active pumps are approximately 10% of the total pumps, and if the number of pumps which are recruited, that will determine acid. So like after we had meal just now, so after that the more pumps will be recruited and more acid will be secreted. So food will be one stimulus, there can be other stimuli also. So variation happens, as I explained you, due to number of pumps recruited. This will come very handy as we go down the talk. So the plasma half-life, when we talk of PPI, we talk of two types of half-life. One is plasma half-life. For most of the PPI, plasma half-life is very small. So this varies from type of PPI, 30 minutes to 120 minutes, the drug will disappear. So PPI will inhibit only the active pumps. So all those 10% pumps which were active, they will be inhibited. 90% will go scot-free, and they are ready to bounce back on the battlefield as the stimuli arrive. So if we have given PPI, 10% pumps are inhibited, and if we give a stimulus, say for food, another 10% will be recruited and acid secretion will start. So you don't get full efficacy from the very beginning. In contrast, there is another concept of pharmacologic half-life. This comes into consideration when we achieve full acid suppression, which is by the day 5 or day 7 of use of PPI, when you be used in the dose of OD or BD schedule. So then the pumps are inhibited, but those are inhibited will remain inhibited, need to be regenerated, and regeneration time will vary from 24 days to 7 days. So that is the concept. So when we talk of PPI, there are 3 types of preparations of PPI. One is delayed release preparation, and here we don't need to time the intake of tablet. Normally PPI are given 30 minutes or 60 minutes before meals. So when you are using IR preparation, instant release preparation, so that need not to be timed like that. In contrast, the standard delayed release preparations have to be timed with meal. So why so? Because these are the pro-drugs. First of all, they need to go to pump, get activated there right in the pump, and then they will act. So there is a lag period. And second is because they are acid-level drugs, so they tend to get denatured, so they need to be given in a coated preparation, so the drug is released in the duodenum and not in the stomach. But we have another type of drug, same drug given in a different preparation, like we use in some of the IBD preparation. So that is given in dual release form. So 25% of the drug will be released like a IR preparation, and rest 75% will be released as a DR preparation, delayed release preparation. So what happens that I am going to show you in a short while. So if you want instant acid suppression, obviously DR preparation or delayed release preparation is standard which we tend to use. That is not good enough, because that will result into acid suppression, full acid suppression after several days. So that is of no use. So we have IR preparation. What are IR preparation? They will be released in the stomach, but because they are acid-level drugs, so they are given some protection from acid. How they are given? Generally, there will be something which will neutralize acid, and most commonly you understand what will neutralize acid is sodium bicarb most commonly, but there are other agents also. So they will be protected from acid. So they are IR preparation. So they will be absorbed, and action will start early. So if they are given 6 hourly, say for, so there will be acid suppression on day 1, but still not with the first dose acid suppression. So this is dual release. What I showed you, I told you that the half-life or plasma half-life is just 30 to 120 minutes. Here you are seeing 2 peaks, and the second peak is giving you significant plasma level up to 9 to 12 hours. So effectively this becomes independent of meal intake, independent of or stimulant, and this will give you better efficacy. So this is how it looks like in contrast to delayed release preparation, which you are seeing here. So this is fading away quickly, whereas delayed release preparation is giving significant plasma level even up to 9 to 12 hours. So that will give. So delayed release preparation, dual release preparation, if you are using, it need not be timed with meal. It can be given independent of meal. The second point, one should remember that all omeprazole, pantoprazole, rabeprazole, milligram by milligram have different potency, and they have to be used appropriately for the given agent. So pantoprazole 40 milligram will be equivalent to rabeprazole 20 milligram. So erroneously, no one should be using that rabeprazole 20 and pantoprazole 20 is both are same or both are equivalent. So they are different doses. So there are multiple issues with PPI use. One is it is a pro drug, so there is delayed onset of action. It is acidly wild drug, so to be given as delayed release preparation or entry-coated preparation, it takes several days to achieve the maximal acid suppression. It blocks only active pumps, and the passive pumps which are not secreting acid, they will not be inhibited by PPI. And then for emergency use, like in the bleeding peptic ulcer, we have to use continuous IV infusion or frequent IV boluses. Then there is issue of CYP2C19 polymorphism. This is one polymorphism which affects the metabolism of the drug, and in rapid metabolism results into loss of efficacy or poor efficacy of PPI, and this polymorphism is seen in 2 to 20% in West, but fortunately in India this is seen in only 1 to 2%. So this is not a common problem in India, but Western world it remains a problem. Then it needs time to be with meals, and then there is issue of nocturnal acid breakthrough, which I am going to discuss subsequently. And then most important step and most neglected step, deprescribing PPI is a task in itself. It has to be tackled in a scientific manner. Otherwise, most of the patients will have acid rebound or relapse of the symptoms. So then there are adverse drug reactions. So rebound hypersecretion, though somebody who is taking PPI more than 4 to 6 weeks, if it stops abruptly, so then there will be rebound acid hypersecretion and patient can have symptoms. This is such a prominent phenomena that even if a normal subject is given 6 weeks of PPI and withdrawn abruptly, they will start having dyspeptic symptom or reflux symptom. So deprescribing is. Then there is nocturnal acid breakthrough. This is described as pH less than 4 anytime during night hour for continuous 60 minutes. So that is the definition. And what is the significance? Because in grade C or D esophagitis, this is important. In Barrett's, this is important, and particularly what you say scleroderma esophagus, where you have significant risk reflux problem plus esophageal dysmotility, there it will be very significant problem. So nocturnal acid breakthrough, like acid breakthrough during certain times will happen in all the patient, and if we do 24-hour pH metry, this is how a normal graph looks like. So the line which you are seeing in the middle is the pH 4. So pH will drop, esophageal pH will drop, but rapidly recover. So you understand that there is volume clearance and then there is pH clearance, both will happen and it will recover. In contrast, in GRD, these pH drops are long lasting and will sustain. So the same happening when on PPI during night hour, that is called nocturnal acid breakthrough. So typically that occurs late in the night, early in the morning, depends on the medication. So this is not a rare phenomena. This occurs in 70% of the patients taking even twice daily of omeprazole. So, but with different PPI, the frequency will be variable. So when does it occur? When PPI is taken once daily before breakfast, it occurs somewhere, starts around 10 p.m. But if it is taken as twice daily PPI, then it will occur between 1 a.m. to 4 a.m. So early morning it will happen. And when do you try to look for? In the persistent of symptoms, or when there is high grade acid suppression you want because of Barrett's or grade C or D or refractory GRD. So how can you treat? A strategy to treat is to use the PPI which is associated with less nocturnal acid breakthrough, or you use add a small dose of standard dose of H2 receptor antagonist at bedtime, but still better efficacy will be, this is H2 receptor antagonist data, and still better will be to use nocturnal PCAP which we are going to talk just now. Otherwise IR preparation can be used. So this is what it is recommended for nocturnal acid breakthrough. The physical measures like head elevation, H2RA possibly, and then IR preparations or anti-reflux surgery. So this is some Indian data that 39% patients had noxalenol acid breakthrough, but there was poor relation with the symptom. But recently we have more better options, and now what we have is called PCAB. So potassium competitive acid blocker, vonoprazan, which has come in the market. So this is the licensing of this drug is different in different companies. Initially, US it was licensed only for H. pylori eradication as a combo preparation, which was subsequently broadened. In India, the licensing is for all acid-related disorders. So we are free to use in dyspepsia, ranging from dyspepsia GRD to H. pylori eradication. So where does it differ from PPI? So first of all, it acts on both active and passive pumps. A huge advantage, because I told you that if the onset of action is quick. Even with the first dose, you get peak acid suppression. The second, it need not to be timed with meal. And it is an active compound, it is not a prodrug, so need not activation, and the plasma half-life is long. So again, that is reason for bigger acid suppression, and the CYP2C19 polymorphism which we talked, that doesn't affect much the vonoprazan. So what it translates practically into, so it translates into better efficacy. So severe reflux esophagitis, grade C or grade D LA, so it had better efficacy compared to any of the PPI. So this is in the trials, this is in the meta-analysis. So this is the preferred drug as of now. Even in the peptic ulcer disease, this has shown better efficacy, superior performance in ulcer healing rate, and also for the H. pylori eradication. Because in peptic ulcer disease, you see three issues. One is ulcer healing, second is H. pylori eradication, and third is symptom relief, because all the three don't go hand in hand. So in possibly all the fronts, it is better. The other issue as a gastroenterologist we are concerned is bleeding peptic ulcer, where we urgently require and very effective drug we require. So this is the recent trial, and this compared IV PPI, the standard dose, that is 80 mg of pantoprazole followed by 8 mg IV infusion per hour, compared to oral vonoprazan 20 mg twice daily. And what we have, that vonoprazan had a better efficacy compared to IV PPI. So that is going to be easier treatment, cheaper treatment, and more effective treatment which you rarely see in medical science. Then in H. pylori eradication, earlier when we were trainees, then we used to talk of dual therapy, then we moved to triple therapy, and because of resistance, then we were talking of quadruple therapy, where 2 antibiotics, 1 bismuth and 1 PPI we were using, and still we were hardly ever achieving 90% eradication rate, which was our target. But when we use vonoprazan, it is clearly superior, and the 90% plus efficacy we clearly achieve will triple therapy, and this is comparable or superior to quadruple therapy with PPI. So this is one situation where it will be preferable to PPI for the eradication of H. pylori, and here we don't require bismuth, only the triple therapy will be good enough. And unimaginable things. Now recently we had multiple trials where 2 drug therapy, PPI with 1 antibiotic has been tried and showed efficacy in the range of 80%. Possibly will not happen possibly in India, but in other countries we had multiple trials. So in systemic review, this has been shown to be clearly superior to PPI. So so for H. pylori eradication, there is not much of issue. Nocturnal acid breakthrough, again I showed you data that choice was using multiple dose PPI, IR preparation PPI, but when we use vonoprazan, the frequency of nocturnal acid breakthrough was lowest compared to everything which has been compared, multiple drugs you are seeing here, so compared to all the drugs. But obviously whenever you have anything new, it seemed to be performing well, it will be come at a cost, and the cost can be in terms of financial cost, that is cost of the drug. Fortunately, this drug in India is not very costly, but the second cost which we pay is usually in the form of adverse drug reaction. So we see what is adverse reaction. So most of the adverse reactions are very similar to PPI, simply because these adverse drug reactions are extension of pharmacological effect, and then there are minor adverse effects like nasopharyngitis and diarrhea. But one situation it is very effective is on-demand therapy. This is much more suitable for use as on-demand therapy because rapid onset of action compared to PPI. So this is what. But what I will like to show you these lesions. So all of you do endoscopy, and so these are the lesions which can appear in response to use of vonoprazan on longer term basis or intermediate term basis. So one should be aware that this is sequelae rather than, so this will not be indication to increase the dose, this will be indication to decrease the dose of vonoprazan. So but otherwise generally largely safe, but gastrin rise will be comparable to PPI or even worse than PPI. And again, pregnancy safety data which is available for PPI is not available for vonoprazan, so that is one situation where vonoprazan should be used with caution. And then microbiota changes which are very similar to PPI because that is related to extension of pharmacological effect. So I will say there are certain long-term safety data is not available for vonoprazan. Long-term effect on gut microbiota is not available as of now. There will be rebound acid hypersecretion, although the extensive data is not available for PCAB. Renal safety is long-term renal safety, and occurrence of hypomagnesemia is uncertain, but there is definite long-term increase in gastrin. So PCABs offer faster, more potent and more durable acid suppression compared to PPI. They have a potential place in resistant refractory GRD as a on-demand therapy and severe GRD, and also for peptic ulcer disease. They are generally well tolerated and side effects are minimal and tolerable, but the long-term safety data needs to be seen. Thank you all.
Thank you, sir. Any question? Quick question? So can we? Thank you, sir. Can you invite the next speaker, please?
So our next speaker is Dr. Saurabh Mukeshwar, sir, and he'll be talking on USP on routine.
Dr. Saurabh Mukeshwar. Okay, Dr. Saurabh will be next. Okay.
Our next speaker will be Dr. Anil Arora, sir, and sir will be talking on alcoholic hepatitis. Sorry.
Anil Arora sir is the sir to many of us. He is from Sir Gangaram Hospital, New Delhi. Arora sir, you are invited on the stage.
Good afternoon, everyone, and I'm thankful to Dr. Jayant and the team at Ranchi for giving me this opportunity. The topic which has been allotted to me is management of alcoholic liver disease I'll be primarily focusing on management of severe alcoholic hepatitis. Greetings from Sir Gangaram Hospital. Now, alcohol by default is the only chemical agent or a nutrient which once is ingested has to be necessarily metabolized. It is unlike carbohydrates or protein which can jolly well be stored in the human beings and in the human body. But by default, the moment you start consuming alcohol, it will get absorbed into the blood from the liver, it will be diluted in the blood and has to be excreted. So there is no way you can store alcohol, and hence every single drop of the alcohol immediately has to get metabolized, and there are three ways by which it can be metabolized. These are aldehyde dehydrogenase pathways, MEOS pathways, and the catalase pathways. Almost all patients who drink continuously alcohol, I am going to define what is an alcoholic by the WHO standard, are likely to have fatty liver disease. Unfortunately, 35% of these patients will have incitement of the inflammation triggered by the presence of the fat, and of these, 1/3 to 50% of the patient ultimately will end up with a end-stage liver disease called cirrhosis of the liver, which is a frequent presentation. Who develops an alcohol-related problem? A combination of the factors like the amount and the type of alcohol ingested, the gender of the patient, and genetic factors which are important for the metabolism of the alcohol once it is absorbed, and the comorbidities, especially in the form of obesity, concomitant hepatitis B and C, is what is going to decide whether you are going to have complications related to alcohol ingestion. So this is what WHO has defined as a serotogenic dose of alcohol. So in general, if you have to remember, if a male drinks around 60 grams of alcohol per day and a female drinks around 30 grams of alcohol per day. So this is a WHO definition of a person who is likely to have cirrhosis of the liver related to alcohol. Mind you, only 20% of the patients who imbibe a serotogenic dose of alcohol, that is 60 grams in males and 30 grams in females, are likely to develop cirrhosis. That means 80% of the patients can still go scot-free after drinking serotogenic dose of alcohol. That has something to do with the metabolic capacity of the body. I'll explain you why. So gender also defines who is likely to be affected. So the women in general are more likely to have both alcoholic cirrhosis and other complications related to alcoholic liver disease like alcoholic hepatitis compared to men. So women are about 1.7 to 3 times higher risk for developing alcohol-related liver injury. What happens once you imbibe alcohol? Now, we have brilliant scientists. We have Dr. Mukevad, Dr. Sandeep Pal, Dr. Hitendra, and all of them. If they can come back with a solution in which if you imbibe alcohol, which gets converted into acetaldehyde, it has to be necessarily converted, as I said. And all acetaldehyde then gets converted into acetate. So if front benches can develop a molecule or an enzyme or enzymatic pathway which can convert all incoming alcohol into an inert substance called acetate, then all of us can make merry, we can go and enjoy alcohol. But unfortunately, the first step is easier. All alcohol is converted into acetaldehyde by this enzyme called alcohol dehydrogenase. Subsequently, from acetaldehyde to acetate, this is the rate limiting step. So what happens ultimately? All incoming alcohol will be converted into acetaldehyde, and from acetaldehyde you will have a roadblock. You will have a protest, and this is what leads to accumulation of acetaldehyde, which is responsible for almost all types of symptoms with which the patient presents to you on day-to-day basis, leading to accumulation of the toxic metabolites. Another important aspect in alcoholic liver disease is that because of the deficiency of nutrient intake or because of the metabolic processes occurring within the liver, there is a deficiency of this substance called methionine. Now, methionine is an extremely important substance because this is something important not only in maintaining the integrity of the cell membrane of the hepatocyte, but is also important for production of this sulfurated compounds, of which the classical example is cysteine, which is important for production of antioxidants, something like glutathione. So, moment you have a methionine deficiency, you are more likely to have deficiency of the glutathione, which sensitizes the hepatocytes to development of injury because of the incoming lipopolysaccharide agents. Now, so you have two problems. You have a toxic metabolites which are accumulating in the liver. There is a methionine deficiency which leads to depletion of the antioxidants, sensitizing the hepatocytes to development of the liver injury. So it is a two-way process. So you have, because alcohol is primarily ingested in the gut, it leads to increased gut permeability, permitting inflow of large number of the lipopolysaccharide antigen, which go and stimulate the Cooper cells, which are the resident macrophages within the liver. So a combination of the reactive oxygen species, incoming LPS, as well as the depletion of the antioxidants leads to sensitization of the hepatocytes, leading to the hepatocytic injury. So a combination of the oxidative stress and sensitization of the hepatocyte resulting in hepatocyte injury, and on repeated ingestion of alcohol, you tend to develop fibrosis of the liver, with which the patient presents in our day-to-day practice with decompensated cirrhosis. Again, to stress upon the role of S-adenosyl methionine, this is important for maintaining the integrity of the hepatocytes so that they do not crumble to the incoming stimuli. And secondly, it also supplies the sulfurated moieties to the antioxidants. So if you are methionine deficient, you are more likely to have hepatitis and you are more likely to have oxidative stress. So next time when Dr. Jayant Ghosh invites you for a dinner or a cocktail dinner, remember while ingesting this cocktail, you remember you are taking in a lot of toxic metabolites with oxidative stress, mitochondrial dysfunction, and the agents which are going to hamper and tinker with your immune system. Almost all patients who take alcohol are likely to have fatty liver disease. Some of them get fatty liver disease from normal liver, and some of these patients, depending upon your metabolic capacity and the incoming LPS agents or the depletion of the reactive oxygen species, you tend to develop alcoholic hepatitis or cirrhosis of the liver. How do we treat these patients? The moment the patient comes to you, you have to look at two things. What is the stage at which the patient has come to you? Does the patient have only normal liver still, or patient has only simple steatotic liver disease, or patient has a frank alcoholic hepatitis or cirrhosis? Patients who have an advanced liver disease, whether you are taking alcohol or not alcohol, the treatment does not change. But what is important for us as hepatologists is we have to know this entity called severe alcoholic hepatitis. Now, compared to an alcoholic liver disease, which is a bland fibrotic destruction of the liver parenchyma, here is a disease which is a unique syndrome in patients with active alcoholic liver disease, in which there is an active injury to the liver characterized by bilirubin and rising INR. How do we assess how severe the hepatitis is? There are two scores. One is the MDF, that is matrix discriminant fraction, and second is MELD. So if as a physician or as a gastroenterologist with limited facilities, if you know when you have to refer a patient to a hepatologist, please remember that if your MDF is more than 32 or MELD is 20, this is the patient who needs to be treated at a center which has the facility for advanced hepatology set up as well as for liver transplantation. Because 40% of the patients with MDF of more than 32 and a MELD of more than 20 or 21 are likely to die in next 1 month. Mind you, these are all spoiled brats. These are the people who are young, filthy, rich businessmen, and you tell them that within 1 month you will die. That is something most of the patients are not able to digest. So these are the parameters by which we assess, depending on how many parameters are we using. If you are using just two parameters, prothrombin and serum bilirubin, you can calculate MDF. If you are using three parameters, bilirubin, creatinine and INR, you can calculate MELD. And if you are using more parameters, you can calculate Glaxo alcoholic hepatitis C score and a Lilly's model. So these all tell us how sick the patient is, what is his chance of dying over the next 4 weeks. Treatment basically involves management of alcoholic hepatitis primarily in the form of abstinence. Abstinence means you have to stop alcohol at every point of time. There is no point of time where there is a point of no return. At every point of time in alcoholic liver disease, cessation of alcohol and abstinence certainly adds up to the problem. You can give a lot of drugs like acamprosate, naltrexone, baclofen, etc. But you need a good psychosocial support to make the patient stop drinking. And look at what happens. If you abstain and if you continue to drink, your survival will come down. So if you continue to drink alcohol after knowing that you have an alcoholic liver disease, you are going to have plummeting of your survival. Nutrition is something which is so important in management of alcoholic liver disease. In fact, almost all trials in the world have shown that patients are typically and grossly nutritionally deficient. Even in centers like Veteran Administration in US, if you look at their data, 100% of the alcoholic patients with alcoholic hepatitis are nutritionally deficient. Even though the RCTs have shown that replenishment of the nutrition may not be increasing the survival, but fact is, as a treating clinician, we must make all efforts to undo the nutritional disadvantage which the patient has come. Steroids are the mainstay of therapy in patients with alcoholic hepatitis. In fact, we have the leading hepatologist sitting in this August gathering, and over the last 50 years, ever since they were being used for the first time in 1978, we still have animated, raging debates about the utility of steroids. And as of now, we still do not know what is the place of the steroid. Till recently, this was the publication from multicentric European trial called STOFA trial, which clearly indicated that other than increasing the survival in subgroup of the patient for 28 days, steroids do not have role in management of alcoholic hepatitis. And there are a lot of contraindications. In patients with uncontrolled sepsis, GI bleeding, pancreatitis, concomitant hepatitis B, C, you cannot use steroids. And in my own practice, I think this is what you do. If you have to learn a management lesson, that steroids will give you more trouble than the advantage in alcoholic liver disease. And hence, as of now, we use in a very select subgroup of the patient. It cannot be used routinely. Pentoxifylline is another drug which is a phosphodiesterase inhibitor. Again, the SOFA trial has clearly shown that as of now, there is no advantage of adding pentoxifylline in patient over and above the conservative treatment. Anti-TNF agent, because TNF is something which is so important in injuring the liver. So people thought, why not use an anti-TNF agent? But this publication in Hepatology in 2004 showed that if you give it in the dose of 10 milligram, you are going to kill more patients than giving any advantage in treatment. NAC is something which can increase the microcirculation, but the randomized trials again have shown there is no benefit of giving NAC in patients with alcoholic hepatitis. GCS is something which Hitendra is sitting here, they published their results from ILBS, and we also publish our results from Gangaram Hospital, that in stable cirrhotics, if you give GCSF, you can increase the survival, but it has no role in severe alcoholic hepatitis. But as a clinicians, I think after going through all the glut of available medical therapies, we realize that we have nothing to offer to a patient. Either we let the patient go to a grave or we can transplant the patient. But problem with transplantation in earlier days was that people thought, oh, it is a self-inflicted injury, you are giving a deceased donor, why waste natural resources? Saurabh is here, this was a debate predominantly in the US in DDLT setting. So why waste on a person who's been having self-inflicted injury? But we in India had a different perspective because we were doing LDLT. We thought this is a patient who has a first attack of the disease, maybe he has a good psychosocial support, he's rich enough to afford a donor and he has a lot of finances, why not try it? So based on that premise, we started doing liver transplantation. And this rule of 6 months also is pretty controversial, because all of you would have seen patients who may tell you they'll stop drinking, majority of them do not stop drinking. And even in STOFA trial, it was seen that only about 20% of the patient will have recidivism. That means 80% of the patient will stop drinking after you do their liver transplantation. And Dr. Nirav is here from Apollo. They have now routinely been doing liver transplantation in alcoholic hepatitis. This was based on the data from Lee's group in US, in which for the first time they selected patients with severe alcoholic hepatitis and showed that the results were as good as if you would have done in a bland cirrhotic patient who was decompensated. That means the outcome of alcoholic liver disease with severe alcoholic hepatitis was as good as in those with non-alcoholic etiologies. And hence we started doing liver transplantation in India, and by now we have 1,000 patients who have undergone liver transplantation because of severe alcoholic hepatitis with good results. To sum up, ladies and gentlemen, liver transplantation can be offered to a patient in which we have exhausted most of the therapies, and more often than not, we have hardly any medical therapy to offer to the patient. To sum up, patient with alcoholic liver disease, we should establish their severity. A patient who does not have an advanced alcoholic hepatitis has an MDF of less than 30 or a MELD of 18. He does not need any therapy. The only thing he needs is stop his alcohol, give him nutritional therapy, send him for counseling. Patients who come to you with a higher risk of development of complication are those with an MDF of more than 32 or a MELD of 20. This is the patient, you admit them, try to look at the nutritional status, observe them for 4 or 5 days. If they do not improve, then you try to select which patient will respond to steroids. If there is no infection, if the patient does not have a pancreatitis, if there is no bleeding, if there is no concomitant hepatitis B and C, you can offer them a course of prednisolone with known complications. So overall, to summarize, ladies and gentlemen, alcoholic liver disease is becoming increasingly common. Recently, you would have heard a talk by Dr. Ashwini Singhal that in the Western world, even younger patients at the age of 20-25 are coming down with alcoholic hepatitis. Disease is rapidly evolving and becoming a prominent problem in metropolitan cities, in females also. It leads to damage to the liver because of the concomitant problems of endotoxemia and increased oxidative stress, resulting in fibrosis and development of the liver disease. Lifestyle modifications, simply the abstinence, is the most important part of treatment of alcoholic liver disease. We need to appropriately look at their nutritional status and try to supplement the vitamins which are deficient. Pentoxifine or prednisolone can be used in selected group of the patient with limited efficacy and with flip side, which you have to remember very well. Complementary therapies like S-adenosyl methionine, which is available in the form of Heptral or Nusam and other preparations, does have a very good scientific basis because they tend to maintain the integrity of the cell wall and also give you antioxidants. But somehow RCTs have still not shown their benefit, and time has come, and Neeraj is here, will agree with me, that transplantation is the answer in patients who do not respond to our very flimsy medical therapy. Thank you.
Thank you, Dr. Anil, for an excellent talk as usual. So, very nice talk, and we have covered very important things. And the most important thing, as you told, is abstinence, which is very difficult. And of course, transplant is being done for these patients, but I think the surgeons are not very keen to do retransplant unless until they try to show abstinence.
Yeah.
So, any comments, questions? Please.
Can you have mic? Yeah, I think one thing is important. Earlier we were apprehensive that if you do transplantation, patients are sick, they have coagulopathy. But Neerav is here, he'll support me. I think this was an exaggerated fear. We have seen good results in patients who are otherwise young and have LDLT setting which is favorable for them. Yes.
Hello. Sir, the paper was published in Hepatology 2010. I was doing DM at that time. They showed the patient, those who taking a heavy drink more than 7 or 8 large drinks a day, who stopped suddenly because alcohol helps in the apoptosis also. He said the transient deterioration may, which might be life-threatening. It is in that study they showed those who left suddenly, those who were the heavy drinker, they have a rapid deterioration in the liver function, as the other group of patients, those who left over a period of 5-7 days or 10 days. I don't know. I mean, the reason they given this because the alcohol was the apoptotic agent. So I don't know. I mean, after that, I didn't never read that not been supplemented with the other studies. Is any thought
Yes,
on that?
I'll tell you. The answer is crystal clear. You see, once you have a liver which is damaged to an extent you are dying, any single drop of alcohol is going to be detrimental. What you are trying to point out is the fact that it will do away with apoptosis. Let's understand the basic difference between necrosis and apoptosis. Apoptosis by definition is a sterile containment of a diseased organelle within the cell. Suppose mitochondria is damaged, rather than letting it split into the multiple parts to which the body will react, it will try to contain it as a baggage, which is a waste baggage. But that will occur in a patient where you have a potential for the rest of the liver to get salvaged. So that is a flip side of it. But in a patient who has an advanced liver disease, who has come to you with severe alcoholic hepatitis, even a single gram of alcohol, because of the multitude of the problems which are injuring the liver, is more detrimental than looking at a minor component of trying to prevent apoptosis. I think we have gone far beyond before we think of actual positive value of apoptosis.
And secondly, sir, the STOPA trial only showed 1 month survival benefit. After that, there's no survival benefit.
Absolutely.
So I don't know how many steroid, how much.
Yeah, that is what I see in my own practice. I hardly find I'm able to find a patient who is fit for steroids. That means patient does not have infection, there is no pancreatitis, no bleeding, no SBP, and there is no hepatitis B and C. You hardly find any patient. And I sincerely believe that patients who are destined to improve will improve with passage of time, observation and nutrition. And credit you can give it to Hitendra, you can give it to steroid, anybody you want.
Sir, my query is practical. How many packs equal to 60 grams?
Hitendra, can you just give him the mic?
कोई नाप के पीते तो है
So he's asking how many packs is equal to 60 grams.
कोई नाप के साथ पीता नहीं.
You see, what I think as a hepatologist and a gastroenterologist, it is important. Then you have to understand the language of pegs and the liquid and the ml. What matters is grams. For all practical purposes, 1 ml will be equal to 1 gram. Now, different alcoholic beverages will have different concentration. Peg by definition is any liquid which is 30 ml. That is a peg. So beer will have 4% alcohol, rum will have around 25%, whiskey will have 42%.
Yes.
So depending on what peg you are taking, look at the total volume and convert it into grams. So it is easier to communicate in terms of the gram. Now, desi thara, desi alcohol may have different concentration. But what is known as beer, whiskey, rum, and these concentration are very well known. So look at, suppose 1 peg of whiskey will be far more harmful than a peg of beer because the concentration is almost 8 times more.
Okay, sir. Thank you.
Yeah, last.
Steroid is the approved therapy for alcoholic hepatitis.
Can we have the mic?
Sir, steroid is the therapy approved for alcoholic hepatitis. Is it still approved for the alcoholic hepatitis plus compensated cirrhosis, alcoholic hepatitis plus decompensated cirrhosis? If it is indicated, then what's the difference? Is there any difference in response rate?
Okay, a very relevant question. You should understand, the moment you have alcoholic hepatitis, 2/3 of the patient will have an underlying cirrhosis. Whether you are able to diagnose or not, that is a different issue. 2/3 of the patient with alcoholic hepatitis will have underlying cirrhosis. Now, whether that cirrhosis is compensated or decompensated, that will all depend on your MELD score. In fact, there is a very good article published in Hepatology recently. There is a window period for response to steroids. I'm sure Hitendra and Neera would have reviewed it also. That between a MELD score of 25 to 35, this is the best time when the patient will respond to steroids. That means if you are doing it early, you are giving more side effect, and if you are going it beyond 35, it will be more detrimental. That is in decompensated cirrhosis. Steroids will have their own flip side and more side effects. And if you are doing it too early, you have no advantage. So there is a window period in which will be most effective. But certainly it's very difficult to find out that window also. That is the problem. Because you have so many contraindications.
Similarly, more than DF, more than 100 is no.
Yes, thank you, sir. Can we move to the next talk? Thank you very much, sir. Thank you very much. Can we invite the next speaker?
Our next speaker is Dr. Saurabh Mukevar, sir. Sir is a consultant gastroenterologist at Midas Hospital, Nagpur.
Very good afternoon, all of you. Hi, I'm Dr. Saurabh Mukewar. It's a pleasure to be here in Ranchi. This is my first time to visit this part of India. So I've heard a lot about all the brilliant doctors and IS officers. So it's nice to be here in Ranchi for the first time. So today I'll be talking about endoscopic ultrasound, and we'll talk about some therapeutic indications and sort of going routine and a little beyond that. And just to start off, routine is basically something that's normal and regular. And when I was told to give this talk, and I said, what's beyond routine? It's a little unusual, something exciting, something special. And so I decided to put some cases together, just keep it light. I know all of you are gastroenterologists, so you're aware of the routine indications. So endoscopy is for us upper and lower endoscopy. With ultrasound, we can see outside the gastrointestinal tract. And I think this is something all of you would probably know. But when you think about therapeutic or interventional EUS, we have several anatomies that are accessible. We can access the intrahepatic ducts, the bile duct, the gallbladder, pancreatic collections, the pancreatic duct, small bowel, gastric varices, portal vein. So if we start off with simple therapies, we start with something very basic, which is US-guided celiac plexus neurolysis. So beyond your biopsies, these are patients with pancreatic cancer and abdominal pain, in which you can, excuse me, sorry, I think, yeah, which allows, in which you can essentially inject in a controlled manner and control the pain for these patients. And this is sort of an illustration for the same, and I think something that you're very familiar with. So for us to understand, celiac plexus neurolysis can really take the edge off. It won't completely take away your pain. It's effective, and all these patients end up not having many great options for pain control. So what's come of age is EUS-guided radiofrequency ablation of tumors. And I'll present a case here. This is a patient with 54-year-old male with recurrent episodes of anxiety and sweating for 20 years. So he had negative extensive workup. He would have 5 to 6 meals a day and would wake up at 3 a.m. with hypoglycemia every night. So he would wake up at 3 a.m. and 6 a.m. and have food. So his lab showed elevated serum insulin levels, but a CT abdomen was normal, and therefore the patient was never diagnosed to have a potential insulinoma. So this, so now with EUS guidance, now I just move forward here. So this is a prophylactic PD stent placed, and in this patient, EUS could pick up the mass, which was otherwise not visible on the CT. And it was biopsy proven to be a neuroendocrine tumor. And then we are performing this EUS-guided RFA across the gastric wall, and you can see complete successful ablation of the tumor. A couple of settings were done, and then this is successfully done. So patient had absolutely rapid response in 24 hours, no symptoms of hypoglycemia. So if you see, this is the data comparing EUS RFA with surgery, and we are looking at less adverse events with the EUS RFA and almost equal clinical efficacy. There's some relapse rate, but then patients could be treated with repeated sessions. Management of pancreatic collections. So within the first 4 weeks, we call it acute pancreatic and peripancreatic necrotic collections. And after 4 weeks, we call them pseudocystic and walled-off pancreatic necrosis. So this is a patient with biliary pancreatitis, presented with abdominal pain, fever, vomiting, large amount of necrosis, extending to the paracolic gutters. Something that you see now, I guess, in routine conferences with transgastric placement of metal stent, which is fine for pseudocysts, but now we are doing necrosectomies at our center very routinely, where we do extensive, about 5 to 8 sessions sometimes, for extensive necrosis removal across the gastric wall. We are entering into the necrotic cavity and successfully removing the tissue successfully. Yeah. So if you see comparison, we have learned that endoscopic options, which are minimally invasive, are better than minimally invasive surgical options. And this is consistently proven across multiple studies. So sometimes things can be more challenging than usual, and this is a patient with a migrated stent in the cyst wall cavity, which had collapsed. So here we ended up having to go across the gastric wall and sort of create an artificial cavity, place a metal stent, and then gain access to the cavity and remove the migrated stent. So these are some of the extensions of our standard approach that we apply. Now we are familiar with biliary drainage options, which is EUS-guided choledochoduodenostomy or EUS-guided hepaticogastrostomy or EUS-guided gallbladder drainage. So these are typically patients when we don't have access to the papilla. And I'll show you a couple of patients here. So this is something routine. On the left is a EUS-guided biliary drainage with a choledochoduodenostomy, and on the right is a hepaticogastrostomy in a Klatskin tumor, where we are essentially placing the stent across the stomach and here across the duodenum and creating new anastomosis. So if you see the data overall, the success and complication rates with EUS-guided hepaticogastrostomy and choledochoduodenostomy are very similar, with slightly more risk with hepaticogastrostomy. And in terms of technical success, it's similar, adverse events and similar. And compared to percutaneous biliary drainage, clinical success is favoring EUS-guided biliary drainage. What can we do further? So this is a patient with duodenal stent for mass in the head of pancreas and had biliary obstruction. So now in this particular instance, we are able to gain access across the metal stent inside the bile duct, and we are placing a new stent, which is choledochoduodenostomy, through an existing SEMS. Now this is being done here, and you can see we have gone through the prior metal stent and placed a metal stent into the bile duct. Other instance, this is a patient with obstructive jaundice and cirrhosis, but had ascites. So here we are doing EUS-guided choledochoduodenostomy, and you can see here there's a large amount of ascites, which we tapped, but still there was ascites. And we go here across, and there you go. So that's a metal stent now being placed in the presence of ascites, which has been traditionally a contraindication. At our center, we've done this in about 21 patients, and we compared with another 44 patients who did not have ascites. We found very similar success rates and absolutely no increase in complications. So it's really a feasible option done safely. Sometimes you can go a step further. This is a patient with a complex hilar block. We could not gain access into the right intrahepatic ducts. So in this instance, we go, the ERCP failed. So we went with the EUS across the duodenal wall. Now we are able to access the right intrahepatic ducts. And what we are doing here is a hepaticoduodenostomy, where transduodenal access into the right intrahepatic ducts is obtained. And just like the hepaticogastrostomy, we're doing the hepaticoduodenostomy, right there. Cholecystogastrostomy has now come of age, and we have done quite a few of these patients. And this is a patient with cholecystitis. We are placing a cautery-enhanced metal stent, the Axios. As you can see, this is something you've probably seen in conferences. And what we have is based on data that overall technical and clinical success is very similar to percutaneous gallbladder drainage, but analgesic requirements are much lower. What else can we do in patients with ascites? This is a patient with cirrhosis, elderly patient with ascites. We can also do gallbladder drainage, but again, you have to be very careful when you're doing in presence of ascites. You can see a lot of. And another case here, we are now able to go inside the bile duct. So we are endoscopically visualizing the inside of the gallbladder, and here we are able to remove all these stones from the gallbladder. So something which we never imagined is possible, we can do now. Another patient here with large stones inside the gallbladder. We are performing endoscopic laser lithotripsy of these large stones because this patient was a poor surgical candidate with ultimate clearance of the stones. Something else in patients, this is a patient with symptomatic gallstones, 88-year-old lady, and we could not perform standard cholecystogastrostomy. So we went inside through ERCP, we distended the gallbladder, and now with the distended gallbladder, now we managed to sort of create a new fistula tract and place a metal stent across the gastric wall into a non-distended gallbladder, which is not inflamed. So this is a more challenging scenario. We can do EUS-guided gastrojejunostomy, and I think this is something you've obviously seen quite a bit of, where we are placing a stent across the stomach into the jejunum. But what else? I'm going to skip some of the data. What else can be done? Now, these are cases which are afferent loop syndrome cases. Left is a patient with total esophagectomy and had abdominal pain and vomiting. On the right is a patient with Whipple's having jaundice. And left is the illustration of case 1 and right is the illustration of case 2. In both patients, the afferent loop was obstructed. Surgeons refused to operate, they sent the patient to me, and here we ended up doing internal anastomosis. On the left is a case of US Garrett jejunal-jejunostomy. From the jejunum, we went inside the dilated jejunal limb. Oh, sorry for that. Yeah, so from the, here, let's see, yeah. So on the left is the jejunal dilated limb, where we are placing a metal stent across the prior limb into the dilated jejunal limb. There's something wrong with the AV, I guess. Okay. And on the right, this is a duodenal-jejunostomy, where we have gone inside the duodenal bulb. We can identify the dilated jejunal limb again and decompress this limb by creating a neuroanastomosis. So all in all, the jaundice resolved in both these patients. So if you look at the data, this is pretty effective procedure with almost success rate of 80 to 100%. What else can we do? Now this is a patient with a bowel obstruction, 68-year-old male, catalytic EF of 20%. Surgeons did not want to operate, distended bowel loops. So in this instance, we ended up performing a coloileal anastomosis, and here we managed to get the EUS scope into the right side of the colon. And you can see this is a mass in the colon, the right side. And we went ahead with the EUS scope, and you can see the dilated small bowel loops. Now, this allows us to go from the right colon inside these small bowel loops. And now we are placing an axios to create a new anastomosis. It's an ileocolonic anastomosis that's done. And you can see the duct, the decompression of the obstructed small bowel. I'm going to switch gears and move to the second part of the talk. Let's see here. All right. Okay, so I'm going to skip one of these cases to move to the vascular substance procedures as well. So this is another case here, 61-year-old male with pancreatic cancer and biliary SEMS. Progressive disease, gastric outlet obstruction, pain, and jaundice. So now we are doing all the three procedures in this one patient. We're doing gastrojejunostomy, hepaticogastrostomy, and celiac plexus neurolysis. So all these things can be combined in one-stop therapy for the patients. Going forward, we can do pancreatic ductal intervention. Something can be a little challenging. This is a patient with pancreatic ascites, where ERCP was not possible, and the patient had large volume ascites, and there's a lot of edema. We could not get the scope in D2. So in this instance, sorry, let me switch to duplicate selection. Yeah, so in this instance, we decided to identify the pancreatic duct across the gastric wall, where you can see it's a non-dilated duct, and gain access. This was one of my earlier cases, quite challenging. And well, I'll just move forward to show you, yeah. So that's the cannula across into the distal pancreatic duct, and you can see there's leakage of contrast into the peritoneum, and therefore we ended up performing transgastric pancreatic duct drainage, US guided pancreaticogastrostomy, which worked quite well for the patient. The ascites resolved in 2 days. Something similar, this is anterograde pancreatic transpapillary stenting. Again, due to edema, ERCP was not possible. So here we are going across the gastric wall. You can see the PD, and we see a dilated pancreatic duct, cannot gain access. We place the wire through the papilla into the duodenum, and eventually a stent is now being deployed, as you can see, from the stomach across the papilla through the pancreas. You can also do pancreaticobulbostomy, where you're going across the duodenal bulb. And in this instance, this is a young female, chronic pancreatitis wasn't possible. We placed a pancreatic duct stent across the bulb into the pancreatic duct dilated right there. So if you see overall, it's 80 to 90% success rate. Clinical success can be variable between 70 to 95%. So just show, I guess I'm going to switch to the last part of the talk. Show a couple of instances here. Something you're familiar with is coiling of rectal and gastric varices, but we can apply the same principle to distant areas. This is in D3, and duodenum and right is a feeder for the rectal varices, where where we managed to gain access into these collaterals and successfully deploy the coil and glue into the rectal varices. So now not only limited to gastric, but you can do ectopic varices as well. If the chairperson's permit, maybe a couple of minutes, and yeah, thank you. So this is something very challenging that we encountered. This is a patient with ectopic varices for small bowel. Enteroscopy not possible, patient was in shock. We could not get a scope to the small bowel, neither enteroscopy. So what we ended up having to do here is EUS, and you can see on EUS from the rectum, we could see varices across the small bowel. And you can see here, this was the small bowel varices floating in the ascitic fluid across the rectum. And what we ended up performing in this case is a transrectal transascitic coiling. Now this is ectopic varices, this is a small bowel refractory bleed, and we are going from the rectum, and you can see here now we have gained access to this ectopic varices and glue and coil inject, and a miraculous response. In 24 hours the pressors were off and the bleeding stopped, which was a very, very challenging case otherwise. Something interesting, this is another patient with chronic pancreatitis, recurrent hematemesis, 5 EGDs, 1 EUS, no cause was found. So all we could see was this unusual protuberance in the proximal gastric body, and here the EUS came to rescue, and I'll show you the instance here. This patient had, we did EUS, we found this protuberance, but interestingly what we could see was a dark structure going to the protuberance and not picking up Doppler, and then not picking up flow, but on Doppler we could see that there was some flow in that, and it was actually a vessel. And in this instance, we went ahead and targeted it with the help of linear scope and injected glue successfully into that feeding vessel. So some of these indications you can really extrapolate from your basic understanding with the help of EUS. And lastly, I'll show the last instance here. This is a patient with splenorenal shunt with recurrent encephalopathy. And you can see this is a spleen, the kidneys, and there's a splenorenal shunt. Patient had at least 8 to 10 admissions with encephalopathy. And right, so with the help of EUS, we could find the collaterals, trace the shunt from the splenic vein to the kidneys. And this is the shunt you see here, and let me show you once. Yeah. So this is the shunt, and we can now inject across the gastric wall, gain access to the shunt and coil 1, and then eventually deployed coil 2, and injected glue, and then successfully obliterate the shunt. So now this is a CT 8 weeks later, no additional episodes of encephalopathy after 8 weeks. Sahaj Rathi from BJI has done fantastic work on this. And I think I'm going to switch to this. So in conclusion, EUS has revolutionized the treatment of GI diseases. There are several emerging therapeutic indications of EUS. With novel applications of EUS, you can tackle challenging clinical problems successfully. But of course, a word of caution, once you achieve a certain level of expertise in doing routine cases is only when you should venture into the more challenging ones. But EUS really opens doors to therapies which were otherwise unimaginable. So thank you so much for this. Yeah.
Thank you, sir. Beautiful presentation. You have demonstrated many aggressive interventions also. Any quick question or comment from the floor?
Yeah. What is the trick and what is the intention to perform such type of management, unbelievable management, which are not likely to manage by any conventional methods? What is the trick and what is your intention? How you decide I should take this case for endosono therapeutic procedures?
No, thank you. So I think it's really the clinical need of the patient that drives the innovation or attempts for so, because if you see most of these patients, we really didn't have any option. Surgery would be high risk, and at least 5 or 10 of those which surgeons had refused or sent to us said we cannot operate these patients. So we had to sort of think of ideas outside the box, what else we can do, and it's once you see and it seems like you can do it, and if you have the confidence to do it, then I guess you can proceed with doing it. And I think it is certainly a lot of hands-on. So I'm the only guy doing EUS in a tertiary center, so I do all the therapeutic cases. So that's why after doing say 200 cystogastros or a certain number of gallbladders, you can venture into the more difficult ones and try it out. Once you feel a little more confident of these with your hands.
Yeah, thanks for elegant demonstration of your expertise, and for new beginners or other endosono specialists to go beyond the box. This is the message of the topic. Thank you for your excellent demonstration and expertise. Thank you, sir.
Thank you for the excellent talk. So we'll have 2 sessions on liver transplant. First, Dr. Nirav Goel, head of the Department of Liver Transplant Unit, Apollo Hospital. Sir will be talking about biliary and vascular complications in liver transplant, and following him, Dr. Hitendra Garg will be talking on overview of liver transplant.
Yeah, good afternoon, ladies and gentlemen. I want to thank the organizers for giving me this opportunity. Well, biliary complications is the Achilles heel of liver transplantation, and it is the weakest link to a good recovery of a patient or to a one additional year of repeated hospitalizations and requiring some kind of intervention. So it is the most common post-operative complication, and amongst the biliary we come across leaks and strictures which form the main problems, and then there may be occasional stent-related problems, scars, sludge, etc. And there is a difference which exists between DDLT and living donor liver transplant, and as you know, in India it's primarily live-related liver transplant. But when we talk about deceased donor, the incidence of biliary complications is slightly lesser, with leaks constituting around 4 to 12% and strictures around 5 to 15%. With the pediatric liver transplant, or we talk about split liver transplants, the anastomotic biliary stricture rates are higher, and for living donor liver transplant, by the end of 1 year, around 20-22% of the patients will be developing biliary problems, and at 5 years one expects around 25% of the patients to have landed in the hospital for some bile duct problem or the other. In live-related liver transplant, overall for the recipients, around 5 to 40% complication rates compared for bile ducts, primarily because the bile ducts are really small caliber and you are really cutting right at the junction with the right lobe or the left lobe, and the leaks constituting around 0 to 22% and strictures from 22 to 32%. So a majority of them will be presenting in the first 2 months, and many a times we see stricture presenting as early as 2 weeks post-transplant. But commonly in the first week or to 2 weeks is the bile leaks, which is more of a problem, and mainly related to duct-to-duct anastomosis, and mainly because when we are dissecting in the ducts, there is devascularization which occur. We know the bile ducts, they have the 3 and 9 o'clock blood vessels. They get, if you are dissecting too near the bile duct, they will get injured, and that leads to devascularization of the duct. The donor duct length is also a problem in live-related liver transplant, where we are really, when we are taking the right lobe, we are dissecting between the right duct and the right artery, and the duct may get thinned out or devascularized in this period. Particularly nowadays, when we are doing more and more of minimally invasive surgeries, be it laparoscopic or robotic, you have to really isolate the duct well in order to cut the duct. For deceased donor, where we have longer duct lengths, again devascularization, the higher the duct you are cutting, the better are the results as far as deceased donor liver transplantation is concerned. Along with this, there is also preservation injury, not so much with live-related, but with deceased donor transplants. The longer the cold ischemia period, where you're putting the graft in a cold storage, static storage, the higher is the chance of developing bile duct complications. Though now with machine perfusion, for normothermic machine perfusion, the incidence of bile duct complications have gone down as far as deceased donor transplants are concerned. Again, when we are talking about ABO incompatible transplants, we can have more complications, particularly for non-anastomotic strictures. But majority of the strictures which we'll encounter in transplant are anastomotic strictures. the anastomotic strictures are much more, treatable. They are much easily handled. Majority of the times, the ERCP will handle the situation. Sometimes you may have to resort to percutaneous drainage, lesser, but with non-anastomotic stricture, which is seen more commonly with deceased, with the donation after cardiac death, or you are doing APO-compatible liver transplants. There you may have non-anastomotic strictures where you will have much more graft loss incidence. So the modalities are therapeutic ERCP, then there are percutaneous biliary drainage, and obviously surgical correction, but we keep surgical correction as a last resort because majority of them can be handled endoscopically. The principles involve balloon dilatation and stenting. On an average, about 3 to 4 sessions are required in 3 to 4 months apart. We as a rule, and Dr. Hiten does all our ERCPs, in the first 2 weeks to 3 weeks, there is no balloon dilatation done for the strictures. If required, a stent may be put. We do prefer to do all our endoscopic interventions at around 4 weeks post-transplant because till that time the ducts are not that healthy and the anastomosis may give way when we are manipulating the anastomosis during stenting. Usually dual to multiple stents have better results, and approximately 9 months to 1 year it takes for the entire treatment process to be finished. For patients where ERCP is difficult, particularly when we have 2 duct anastomosis, the posterior duct may be at such an angle that it is difficult to cannulate. Their percutaneous drainage may help. For deceased donor liver transplant, they usually present late. They present with tight strictures, but majority of the time ERCP is possible in these patients. Poor outcomes we see when we have multiple duct anastomosis, as I said earlier, when the duct size is really small. Sometimes, when we are doing a right posterior sector transplant, where the duct size is just 2 millimeter, we anastomose it and it may develop a stricture, it may be difficult to cannulate. And when there is an increased risk of devascularization, particularly now when more of life-related liver transplants, more of laparoscopic or robotic transplants are being done, the chances of devascularization of the duct have increased. And sometimes when we have a great neck deformity, there the cannulation of it may be difficult. You can see as the liver grows, the normal orientation of the duct gets changed and kind of bends over at more than 90 degrees, the duct, and that creates a problem in cannulating these ducts. Success rate for live-related is around 60 to 75%, but I would say in our unit it's close to around 85 to 90% success rate with ERCPs, and stricture cannulation is easier for DDLT as compared to living donor liver transplantation. As I said, percutaneous procedures we reserve for patients where we are unable to cannulate with the ERCP. Sometimes a hybrid procedure is done where after railroading through the percutaneous technique by ERCP, then a stent is placed. And for non-anastomotic strictures, the success rate is pretty dismal, and these patients usually end up with a retransplant at a later stage. Surgical treatment, I'm a surgeon, I'm talking in a gastro conference, so I'm not going into detail about surgical treatments, but yeah, hepatovaginostomy, choledochotomy, dilatations, everything works once we have a failure of endoscopic therapy. For bile leaks, the treatment is not much different, but as I said, in the earlier phase, in the first week to 10 days for bile leaks, we'll handle with percutaneous drainage or a lavage. If we have to resort to stenting, no dilatation of the duct to be done, just a stent to be passed in. So at Apollo now, in the past 7 years, we've done more than 800 transplants. Amongst the adult transplants, around 12.6% is the bile leak rate. And amongst these patients, amongst those with bile leaks, 30% we managed conservatively. Drainage, percutaneous drainage, we did in about 19% of patients. About in the first 2 weeks, about 38% for bile leaks required re-exploration and creating a controlled fistula. And ERCP for leaks only 32%, because ERCP in the early phase can itself be a problem. But For the major leaks, amongst these patients with bile leaks, 12% patients with bile leaks, 70% were major leaks. And if we look at major leaks overall in our data, it stands around 8.8%. For the biliary stricture, about 26% is the bile duct stricture rate when we are looking at them at a median at a follow-up of 5 years, and amongst the bile strictures, 95% we have handled them with ERCP, and some of them would be a combination of PTPD and ERCPs, particularly when we had 2 ducts. We have also resorted to intraoperative ERCP and balloon dilatation in about 2%, and redo hepatocogenostomy only in 3% of patients. The majority of them we can handle by endoscopic management. Also, vascular complications is uncommon in the post-operative period following transplant now with the expertise which is available. And pre-operative vascular assessment is important. We do not hesitate to do a transplant where 2 or 3 arteries may have to be anastomosed. It's no longer a contraindication. And but if we have a hepatic artery thrombosis, then we would prefer to redo the artery rather than resort to an angiographic treatment for that in the first week or so, because it always gives very good results. There are multiple arteries usually available, and we can always re-anastomose with another arteries. And more than 75% of these patients can be salvaged. So the optimum modality is determined by the condition of the patient, the viability of the liver. I mean, like if we do Doppler ultrasounds twice a day for the first 5 to 7 days, and any suspicion we'll resort to a CT angiography, and that would give us the viability of the liver as well as the we diagnose thrombosis, and then we resort to, as I said, in the first 3 to 5 days, 7 days, we'll go by for redoing the anastomosis. Beyond that, we'll do a angiographic thrombectomy and sometimes a stenting. Portal vein thrombosis is uncommon. It occurs in 1 to 4%, and but if it is left, 100% graft loss in the early post-operative period. And in pediatric patients, portal vein thrombosis is the Achilles heel. We do a lot of pediatric transplants, and we come across really bad portal venous anatomies where you have a blocked portal vein, coronary vein shunting blood away, and in this particular patient, IMP was shunting the blood away. Then we have cystic degeneration where the compression also blocks the portal vein. So when it is diagnosed, usually on ultrasound, we do a CT angiography and then go about doing a percutaneous stenting. We have devised a very unique intraoperative maneuver where we do an intraoperative portal vein stenting. We published this recently. And with this technique, we have never really come out of the operation theater with a blocked portal vein. We're always able to manage opening of the portal vein in a pediatric patient. And these patients I'm talking about are 4, 5, 6 month old babies. This stenting technique has really, salvaged so many times the problem. So this is one of the patients with a post-operative CT scan after thrombectomy and a stenting intraoperatively. So we recently analyzed about 188 patients of pediatric transplants where we did reduced liver transplants, and around 13 patients had portal vein complications. Intraoperative stenting were done in 8, and about 5 patients required percutaneous procedures to deal with the thrombus. And we have modified our surgical technique for anastomosis to an extent that now, in the past, this data is of December 22. Now, in the past 3-4 years, out of 120 odd patients, only 1 patient we experienced portal vein thrombosis in the intraoperative period. Vascular complications overall are pretty low. In the pediatric, hepatic artery thrombosis is 1.7%, in adults around 2%. Hepatic venous complications, pediatric, around 2.6%, mainly because it's a left lateral lobe anastomosis in the adults, with the right lobe 1.3%. And IVC thrombosis mainly seen in pediatric because many a times you'll have thrombosed IVCs right from the beginning. from since birth, and these veins we have to reconstruct. So now about more than 500 pediatric transplants. We are the first unit to cross that number in the country, and in our adult patients, the most common etiology in India, anything proven otherwise, is alcohol-induced liver cirrhosis. So I would like to conclude with these key points that biliary complications are higher in living donor liver transplant, and it is the Achilles heel of transplant, and avoiding devascularization of the duct is paramount. One should prevent a prolonged cold ischemia time, particularly with DDLT now with the machine perfusion. This has directly been addressed. Endoscopic management is the mainstay. Hepatic artery thrombosis is more related to technical issues. It is no longer a contraindication whether we have 1, 2, or 3 arteries to anastomose. And portal vein thrombosis is higher in pediatric population, though with the innovations which we have been able to do, we've kind of tackled this situation as well. Thank you.
Yeah, excellent presentation. A lot of experience in pediatric liver transplant and adult liver transplant. And you have tackled all the complications, biliary complications and vascular complications. You have nicely elaborated. Any questions from the... Yeah. We came to know that vascular complications are likely to be managed. We have moved much ahead improving the life of the liver transplanted patients and decreasing the complications of liver transplant related complications. Thank you, thank you.
So please, one question, I think, one question from the floor.
So regarding biliary complications, we are practicing in Ranchi, Jamshedpur, these places. Generally, these patients have come, they have been stented at a liver transplant unit, the parent liver transplant unit, and then they have come to us. So they don't want to go again and again for again re-stenting or stent packing, stent removal. So if these patients have the stent, they don't have a stent anymore, the stent has migrated or there, and the liver function is showing only a slightly raised alkaline phosphatase. And we do an MRCP and we find in the right posterior, right anterior, there is a stricture but not a complete. What should be the approach? Should we send them again or follow up with LFT, send them back to the parent unit?
See, there was a time in the early phase of our transplant experience that for such patients we would just sit on it and we do nothing about it because the liver function of the patient is asymptomatic, mildly elevated enzymes.
It was a precious liver, so
yeah. But you know, you follow them for 2 years, 3 years, and you start seeing that that lobe will start becoming, that part of the liver will start becoming atrophic. It actually is developing secondary biliary cirrhosis. And now we have a very good experience, a lot of expertise in handling such patients, and as Dr. Etienne is here, he handles them. So now even for mild elevations in liver enzymes, even if the bilirubin is not going up, we are diagnosing a stricture, we'll address it now. Though I would honestly say 3 to 4 years back we would leave such patients, but now with the expertise there, we handle these patients as well.
Secondly, since this is more than 3 years, 2 years now, and the stent has migrated, can we also try Hurricane? Because now, would it be very difficult for us to do it, or should we? Because
it depends on the
other indications.
If the liver functions are kind of stable, okay, that means there is enough of an opening for it to be draining out. So probably it may be okay to attempt it, though I'm not sure. It depends on how difficult it was in the first sitting.
Thank you very much. Can we invite the next speaker?
Next speaker for the day is Dr. Hirendra sir. He is Senior Consultant Indraprasth Apollo Hospital. I'd request Dr. Hirendra Garg sir to come up on the stage to speak on the topic Overview of Liver Transplant.
Thank you, Dr. Jayant and team who's inviting me here. I'll be speaking on this, the overview of transplant. We'll speak on what the protocol we are following and what we are doing, what are the experience of our unit. So if we talking about in India, around 1 million cases been diagnosed and 30 50% of them were the decompensated. Means almost 3 lakhs decompensated cirrhotics being diagnosed every year. And the median survival of decompensated is only 2 years. Out of, in India, if we talk about the requirement of a liver transplant, it's going to be 5,000 to 30,000, but only 18,000 liver transplant being performed as per year, and that to a center 80 to 90 active centers in India. So end stage liver disease, more than 2 million deaths being seen worldwide. So liver transplant is the effective and life-saving, and but the problem is you need a very experienced, significant operative risk, consumes enormous medical resources. So careful selection of the patient is critical. And the deceased donor transplant is very rare, especially in the northern part. And you can see mostly deceased donor liver transplant is mostly in the southern part, where you see to the tune of around 5%. So the worst complications being said, the worst complication of a liver transplant is to die before receiving a liver transplant. So first transplant being performed in India was in 15th November 1998, and till date from there to now we have done more than 4,000 transplants. So the most common etiology, if we talk about, as been told, Dr. Niravis, was the alcohol, and in the pediatric was the extrahepatic biliary atresia. So the newer things which we are doing recently, before 4 or 5 years, if hepatitis B DNA is more than 2,000, we used to give the HBIC. But since the largest study is coming from the Hong Kong, they were not giving the HBIC, whatever the DNA was, and they were managing with the nucleoside and nucleotides, oral antiviral drugs. So the same thing which we are doing is, we are not looking at the DNA, though we started the oral antivirals before the transplant, but definitely we are not looking at the DNA just before the transplant, and we just continuing the oral antivirals after the liver transplant. Similarly, the child B, usually we treat patients before the transplant, but for this child C, after the transplant we start the sofosbuvir or valproatin, which is a pangenotypic cover. We start after the 7 to 10 days after the liver transplant. So should we all liver disease, cirrhotic patients should be transplanted? One should not, because we need to select those patients, the survival is, expected survival is the less than 1 year. So to whom, this is a child score, I'm not going detail of it, it's a MELD score. Based on this child score, if you look at the child C, the 5-year survival is less than 5%, and 1 year is 20 to 30%. So with the transplant, survival is more than 90% at 1 year and more than 80% at 5 years. So if you look at the MELD, you can see after the 19, the survival days after the transplant is more. So for the MELD score, after the between 15 to 90, and child score late B or child C is actually require the transplant. So this is a DMICO classification, where if you have ascites and the varices, this survival is less, 20%, and if both is there, bleeding, varices and the ascites, the mortality is very high. So in these two cases, you need a liver transplant. So probability of death is, if you are having a variceal bleed, controlled ascites, SBP, HE, HRS, the survival is decreasing. And if you do the transplant in these patients, the survival is to the tune of 85 to 90%. So transplant if late B, MELD more than 15, first major decompensation, type 1 hepatorenal syndrome, fulminant hepatic failure, SCC, we usually follow the UCSF criteria, and the rare condition, the blood carrier and the cholestatic liver disease. The absolute contraindication, if we're talking about, severe MAP is more than 50 millimeter of mercury, active substance alcohol abuse, but these days not a absolute contraindication. Patients comes to us with a recent alcohol, they say that we have a donor, we have a money, please do the transplant. So now this is active substance abuse no longer become a absolute contraindication. AIDS defining criteria is of course a absolute contraindication. Any extrahepatic malignancy or a SCC beyond the liver is the absolute criteria for it's an absolute contraindication for a liver transplant. So for hepatocellular carcinoma, the two criteria we follow, the Milan criteria and the UCSF criteria. Milan criteria, if there is a AFP, even if patient filling into the Milan criteria, if AFP more than 100, we do not transplant. We usually do the local regional therapy to bring down the AFP to less than 100. And similarly, UCSF criteria, and we, if the AFP is more, and then AFP is more than 500 or more than 100, we bring it down by the local regional treatment, and then we do the transplant. With the Milan criteria, we have a recurrence rate of 10%. With the UCSF criteria, then the recurrence rate of SCC in a new liver is around 20%. So what about the tumors beyond the UCSF? So where the vessel is not involvement, we do the PET-CT. If there is no METs, downstage the tumor, TACE plus SBRT or tear, or reassess at 8 weeks. We specifically look for the alpha fetoprotein. If it is less than 100, do the PET-CT. There is no extrahepatic disease, we do the transplant. But in these cases where we took out the data, the recurrence rate is around 30%. So about the tumors beyond the UCSF, when there is a vessel involvement, portal vein thrombosis, again PET-CT, no METs, we downstage the tumor, especially we prefer the tear, oblique the TACE versus SBRT. We reassess the patients at 12 weeks, but the PET-CT and AFP, but these most of these patients, they never fit into the transplant. However, we did 3-4 patients in transplant where the portal vein thrombosis, tumor thrombosis is there. So important thing, whenever I call it is where I get a call from the periphery, who can be the patient, they know the patient, but who can be the donor? The important is that should be relative to the patient, first degree relative. If first degree not, but there's a lot of documentation needed for if a second degree. The age is 80 to 50. We have taken a 57-year healthy donor. There should not be diabetes, should not be having a hypertensive, uncontrolled hypertension. Smoking and contraceptive pills should be off. BMI less than 27, but I think it's been taken 33 BMI for a donor. The acceptable remnant should be 30%. Up to 70% we can take out and transplant it to the recipient, and LAI of more than 5. And of course the blood group match, though there is a ABO compatible, I'll show to the protocol of our unit. The size of the graft is very important. GRWR more than 0.7. The quality of graft, we do not accept the fat more than 20%. Type of the graft, right and left lobe, though it says now the study shows both the right lobe or the left lobe, the survival is equal. The anatomy of the graft. The anatomy of graft, all this based on the portal vein distribution. This is a ischemic line, the right lobe, left lobe, hepatic vein, and this is a based on portal vein, based on the portal vein. So important is in the LDLT is the donor safety. This is a top priority, and we every unit takes the healthy young donor. The excluded fatty livers we do not take. I told you in the beginning, we do not take more than 20% fat in the liver, in the donor. Adequate volume, 30% of the remnant has to be with the donor. High quality imaging to look for any anomalies. Left-sided, like the left-sided gallbladder, we do not take those because sometimes the portal vein anomaly has been associated with the left-sided gallbladder. So we usually discuss all the cases 1 week prior, separate counseling session, detailed presentation to the ethical committee. The the risk for the liver, for the living donor is because it's a complex surgery, bile leak stricture, well recognized complication. Till now, I've been there from 2014, been seen around 2,000 transplant, and I've done 2 ERCP in a donor. So only 2 patients, all of them were the stricture, there was no leak. So the stricture or bile leak is very rare in donor. Psychological trauma, of course, if we do not tell the patient to the donor if recipient died, we usually tell to the relatives. So especially nowadays the ALF comes to us when the patient is grade 2, grade 4 in CAF. We usually intubate the patient. We started the CRRT when the ammonia level is more than 100. When we start the CRRT, this allows us more time required for the preparation for the transplant, and CRRT continues 2 days after the transplant. And if ammonia level decreases less than 100 on a 2 consecutive times, and within the 12-hour CRRT, transplant can usually be delayed, and the CRRT required, usually we do 72 hours to 5 days CRRT. If ammonia level rises within 12 hours with the CRRT, we definitely we push the relatives to go for the liver transplant. And we have saved quite a few patients even without a liver transplant, those who refer to us for a liver transplant. So we're just talking about the ALF. This is if we did the 2 ABO incompatible ALF, both one was died after 6 months, and another is still we have done recently. We just given it a rituximab. We have taken up for transplant. We did some plasma exchange after the liver transplant. So the ALF till now we have done 25 in past 4-5 years. We did the 25 ALF liver transplant, and the survival to the tune of 87%. So this is a ABO incompatible transplant we did, some of them the pediatric also. To the surprise, when we take out the survival data, the ABO incompatible, the survival is better than the ABO compatible. Reason behind, because these patients are relatively stable. They were not like ACLF grade 3 multi-organ failure, because in those cases you can't do the ABO incompatible liver transplant. So ABO incompatible, this is our protocol. We give the rituximab 2 to 3 weeks prior. We measure the antibody titer. At the time of transplant, the antibody titer has to be less than 1:8, and splenectomy, routine splenectomy we usually do not do, because there are chances of infection, chances of bleeding. But if patients after the transplant, even after the plasma exchange, if the titer going up, then we do the splenectomy in those patients, and we manage we manage with the tacrolimus, MMF, and the systemic steroid. We intervene when there is a titer goes more than 1:32. We need to give the bolus of either the plasma exchange or the pulse of steroids. So this is the same. This is the paper published in the JHIP where they transplanted ACLF grade 3. They showed that with the transplant, the survival rate is around 1 year survival rate is around 83%, and when they didn't survive, they didn't transplant, the survival is around 8%. So in our unit, we do patients of ACLF, we didn't divide into the grades. Those who manage conservatively, those we have transplanted, and you see that the survival is death is 18% in patients those we transplanted, and those being conservatively managed, they died around 60% of them they died. So the post-LT there's no difference even if the ACLF grade 1, 2, 3 after 1 year survival rate is same, and according even whatever the ACLF grade. This is again published in the Hepatology. So CKLT we did till now we did 19 CKLT patients. Of them the 2 died. and the most common reason is the diabetic nephropathy and the hyperoxaluria, and the survival is around D90%. The LDLT versus DDLT, this is a year-wise survival. So if we look at the death versus DDLT and LDLT, see initially there was no DDLT, but later on, 2028, we did quite a few deceased donor transplant, maybe because of the awareness programs. So if as I told in the beginning, some of the patient, they comes with I have a donor, this is a patient, you need to transplant. Even we have seen patients, those who having a less than 1 month of a alcohol, if they continuing the alcohol within recently less than 1 month, in those patients we see the ACLF, the ALD recidivism is around 7. They again go on to the alcohol consumption, 7 patients. The SCV progression is been seen. This is earlier data because previously we see patients from the Pakistan. We receive the patient from the Pakistan, from the Southeast Asia. So in those cases we have treated the post-transplant 5 patients. SCC recurrence, I told, if we take its Milan criteria, 10%. If it is UCSF criteria, it's around 20%. So complication of immunosuppression, nephrotoxicity, is of course 10%. If you look at after the year, tacrolimus is around 10%. Some of the patients, they have a cardiovascular complication as well. The risk of infection, the risk of malignancy. Recently, we have seen the lymphoma in patients of post-transplant 1 year later. So to conclude, is indication is same. The high MELD child CPD score should be transplanted. We follow the King's as well as the dynamic criteria for the ALF for a transplant. And some of them, like the portal vein thrombosis, or some of which we see it's a contraindication. Now we do, because of the experience has pushed back the many contraindications. So this is the few photographs. This is the patient comes to us with this is a Filipino, and this is after 1 year of a transplant. This is again a Philippines baby. The smallest baby we transplanted is 4 kg. This is again after a 1 year photograph of the 1 year of a post-transplant. This is a girl we received. This is Budd-Chiari syndrome. She came in a very bad shape. This is when she got married, and this is a Indian patient, very cachectic. We managed initially with putting a RT tube, then a 1 month, and then this is 4-month liver transplant. This is a patient we transplanted some other test center, and they again came the graft loss, came with the ABO incompatible. It's a very difficult retransplant in an ABO incompatible. The sister donated, wife donated, and the patient going home happily. This is the hereditary hemorrhagic telangiectasia. Patient is bleeding multiple sides. A long vessel, tortuous vessel of common hepatic artery, which Dr. Nirav reduces as to a smaller thing. And patient, this is from the Bangladesh, wife donated the liver. So it's also going 2 months after the transplant, it's going home. This is a girl from the Faridabad, ABO incompatible acute liver failure because of unknown reason. The Mosi donated for her, and she is again going home after a transplant 1 month. This is a Budd-Chiari from the Saudi Arabia, been transplanted in Jordan or somewhere, came here, again we retransplanted this baby, and this is during the hospital stay, and this baby also gone home happily and still doing a normal life. This is our team, anesthetist and whole team. This is our core team where Dr. Nirav is heading the team, and me as a pathologist, Dr. Arun, Dr. Pradeep, Dr. Varun. Thank you.
Thank you, Dr. Hitendra. Beautiful insight on liver transplantation. Any question and comment from the floor?
Yes. So, plasma exchange we do not use in ALF because there's a lot of volume shift. But there is a paper from the ILBS, they show it is better. But when we do plasma exchange in a ACLF or ALF, because there's a lot of volume shift, patient goes in a hypotension. If a patient is having a underlying sepsis, it's been deteriorated. Our experience with CRRT is excellent. So we are not, especially in ALF, we are doing CRRT over the plasma exchange. But definitely there is a paper from the ILBS. They showed the plasma exchange is better. No, not in all patients. ALF may we do once there is a ammonia is more than 100 and a patient is in grade 3, grade 4 HE. And if ammonia is more than 100, definitely yes. There are many 3-4 studies that showed there's a herniation if the ammonia level is more than 124. So we try to keep them less than 100, at least 2 occasions, and then we try to wean off the CRRT and off the sedation. Large liver. There's no sepsis also. And no sepsis. If there's no sepsis, you did the plasma exchange. We of course, as sir already said, it's whether the patient's inherent immunity or patient is getting better by own, or you start the steroid because there's no sepsis for 1 month. If it's less than 1, yeah, it's coming in the responder range. So I think 40 milligram, irrespective of the weight, you should continue for a 4 week. Yeah, definitely. There is no ascites, only bilirubin, no sepsis, getting better with exchange, and the steroid. I think Dr. Arora also put a highlight. I think we should follow these patients. Should not send them for a liver transplant.
And second is, you said about substance abuse. We have patients who have ACLF active syndrome. They come with ACLF HE and then on triple case diagnosed with a large liver mass.
Large liver mass. I mean SCC.
More than UCSF 9 centimeters. This is the patient right now. Grade 2 encephalopathy, INR 2.2. In these kind of patients, should we push them for liver transplant?
Of course, these patients definitely need a liver transplant. AFP, I don't know what was the AFP, but we follow the UCSF criteria. If it's outside the UCSF, we downsize it and reassess after a 4 week.
But with ACLF also you will downsize?
Yeah, of course, with the taste.
You may not be able to downsize every patient, particularly if they are decompensated cirrhotic, but downstaging is not reducing your recurrence rates. Downstaging is telling you whether your tumor is, chances of its recurrence are lesser or not. If it is behaving well after downstaging, your biological markers are reducing, it tells you that post-transplant recurrence rates chances are less. But downstaging per se is not reducing your recurrence post-transplant. So if a patient does not have a contraindication, no vessel infiltration, otherwise okay, biological markers are not that bad, directly do a transplant.
In the ACLF, I don't think that you'll be able to do a downstaging.
Yeah, you won't be able
to. If the bilirubin is more than 5,
of course.
The important
cheese.
ACLF will have a bilirubin.
Contraindication.
So if the patient fits in for a transplant, with the HCC otherwise, you can go ahead and do a transplant otherwise also.
Yeah, of course, completely agree. More than 5 you can't do the trace. More than 5 bilirubin you can't do the transplant.
With plasma exchange we have...
Size is matters only. You can't do the test, then you have no other option. You have to go for a liver transplant.
In plasma exchange, then we have slightly different experience in ALF. In ALF, at least, most of the times you won't have a donor. The situation is the time is the essence. So in both the situations, when I feel even if you have a donor or if you don't have a donor, in the waiting period you can initiate PLEX or CRRT depending on your choice, because there are situations when you are waiting for the actual transplant to happen, you might have the raised cerebral edema and the patient may become non-transplantable. And before this ILBS experience, the original STAL paper 2017, that is the most valid indication. If there is a most valid indication of PLEX, that is ALF. ACLF, I agree that ACLF, whatever you do, these people do not do well, and these are already patients who are outside steroid criteria, which steroid eligibility is also to the tune of 20% only.
But usually we do start CRRT in patients where there is ammonia is more than 100. If ammonia is less than 100, or we monitor twice early. If it's not or grade 3 HE, then only we start. If there is no grade 3 HE, ammonia level is less than 100, we do not start them on a CRRT. We have a good experience with CRRT, whatever the paper says, so we'll go with our experience. We are not need to start with, will not start with the plasma exchange.
So thank you very much. Can we invite the next speaker?
Thank you, sir, for the valuable information. Now I would like to invite our next speaker, Dr. Piyush Ranjan, sir, Senior Consultant Gastroenterologist, Sir Gangaram Hospital, to come on the stage. He will be speaking on the topic when and how to use resmetirom in NASH.
Good evening, everybody. So thank you for accommodating me earlier. So if we look at the problem in this metabolism associated with steatotic liver disease, you clearly see there is a problem. The recent published study shows that nearly 35% of Indian adults have this problem, and there is a high progression. 25% patients are at risk of developing cirrhosis currently. So MASLD is one of the most common conditions leading to cirrhosis and HCC, and there are limited approved therapeutic options for this. And the therapy which we are looking at, what we are looking at is a drug which can reduce inflammation, a drug which can reduce fibrosis, drug which should have a favorable cardiovascular profile because these patients will require long treatment, and at the same time should be very safe. If you look at the treatment options, this is a very busy slide, but don't look at this. If we are looking at the treatment options which we have currently available, vitamin E and pioglitazone in the PIVENS trial, if we look at the parameters, they affect ASLT, ALT, lipid profile, steatosis, inflammation and fibrosis. So none of the currently available drugs, including this GLP receptor agonists, affect favorably all the profile. GLP-1 receptor agonists which we have currently, they do not improve NASH, they improve the steatosis, but there is no documented improvement in fibrosis. Obeticholic acid, we know that it led to some improvement in fibrosis, but did not improve NASH. PPAR agonists, again, approved by DGCI in India, but we do not have biopsy-proven data, so we do not really know whether it reduces NASH, inflammation and fibrosis. So FDA has outlined an accelerated approval pathway for drugs for NASH, and the conditional approval is for drugs which achieve two histological endpoints, that is histological for improvement in liver fibrosis stage and resolution of NASH, and a full approval will be given to a drug which in long clinical term shows improvement in clinical outcomes in form of liver-related events, development of liver cirrhosis, HCC, and death. If you look at resmetirom, and over the next few minutes I will show you how resmetirom at present is probably the best bet. There are a lot of drugs which are coming, the triple GLP and agonist and things like that. But currently, the drug which has been approved in March 2024 by US FDA, resmetirom, ticks most of these boxes. So we'll very briefly look at the two aspects, mechanism of action and what is the evidence from trial. So resmetirom, basically thyroid hormone acts in our body through two main receptors, THR alpha and THR beta. THR beta receptors are present in the liver, THR alpha is present throughout the body, and resmetirom is basically an orally active thyroid hormone receptor beta agonist. It is highly more selective than T3 as compared to THR beta, and it is highly protein bound, so the liver specific uptake is quite high and it avoids the cardiac and bone adverse effects because of this. So resmetirom, you see the mechanism of action as such, once it enters the hepatocytes, it acts on the nuclear receptors, and the activation as such leads to production in a lot of enzymes, and the ultimate effect is that it decreases the de novo lipogenesis, thereby reducing the liver fat. It increases mitochondrial oxidation by producing mitophagy and biogenesis, and by promoting autophagy, it also decreases the lipid metabolism. So complex mechanism of action simplified in these three steps. What it does in addition is that it corrects the intrahepatic hypothyroidism. So what is that? Normally T4 is converted in normal liver by deiodinase 1 into the active form of T3. There are various studies which have shown that in MASH, NASH, whatever we call it, there is a reduction in this enzyme, and T4 is preferentially metabolized to reverse T3 by deiodinase 3. And this drug, basically, this leads to accumulation of lipotoxic contents, and resmetirom corrects this intrahepatic hypothyroidism, and reverse T3, as I'll show you in the studies, is a marker of the efficacy of action of resmetirom, and it also is a mechanism of action of resmetirom. Now, if we look at the clinical data with resmetirom, there is quite a robust data with resmetirom. This is the phase 2 trial which was completed, and I'll briefly take you through the salient points of this. And there are three phase 3 trials: the Maestro NFLD trial, which is predominantly a safety trial; the Maestro NASH trial, on the basis of which the US FDA gave this drug approval; and then this is the Maestro NASH outcome, which is recruiting compensated cirrhotic patients, and this is ultimately, if the studies come out to be good, the results come out to be good, long-term full approval is expected. Now, if you look at the resmetirom phase 2 study here, what was done, that the primary endpoint was a change in MR-PDFF. So basically, till now, mostly the stress was on liver biopsy. This resmetirom has liver biopsy at all the steps, but it has also looked very closely at non-invasive markers of liver fibrosis and other novel biomarkers which predicts fibrosis. So here the primary endpoint was improvement in MR-PDFF at 12 weeks, and the secondary endpoint was absolute reduction in week 36 MR-PDFF, and the liver biopsy was repeated at 36 weeks. All these patients underwent liver biopsy at the baseline. So if you look at the key primary endpoint, there was a significant reduction with both the doses of resmetirom at 12 weeks, both the absolute reduction and the relative reduction of liver fat studied by MR-PDFF, both at 12 weeks and 36 weeks. So what was more important here, that the reduction in MR-PDFF was predictor of degree of improvement in the necroinflammatory activity, that is the NASH, and the fibrosis. And the other factors which predicted improvement in NASH were weight loss and resmetirom exposure. This is very important. Once we start using these drugs, sex hormone binding globulin is a surrogate marker. This is a downstream target of resmetirom action. So measurement of this predicts whether you can reduce the liver fat or not by the drug, the efficacy of the drug. And if you look at the study trial design, there was a phase 2 of this phase 2 study, there was an open label arm beyond the 36 weeks, and there they applied the non-invasive markers predominantly. It is not possible to biopsy these patients all the time, and in our day-to-day practice we need to have a lot of non-invasive markers. So there was a continued reduction of liver fat using MRPDFF, the liver enzymes, and these novel biomarkers, PRO-C3, and we already have this FibroScan and all these, but these are novel biomarkers which predict continued improvement in fibrosis. I am not going into those details. If you look at the Maestro NFLD1 study design, this is basically a safety study. This is not looking, the primary endpoint of this study was week 52 safety and tolerability, and the secondary endpoint was week 52 reduction using the non-invasive markers, and there was a MRPDFF in between, again using the non-invasive markers, the improvement in liver fat. So if we look at the safety data, there was no major treatment emergent side effect. Treatment emergent side effects is a new concept where if you have a particular event more than 10% as compared to the placebo, that is termed as a treatment emergent side effect, adverse event. So there was no major treatment emergent adverse event, and predominantly the shortcoming of this study was that it was done during the COVID period. So there was an open label arm, then there were less treatment associated adverse event in that arm. However, if we look at the efficacy endpoints, which were the secondary endpoints, again, like the phase 2 study, the reduction in liver fats, favorable lipid profile, and the reduction in FibroScan, and again the novel biomarkers which were used in the phase 2 study, they continued to show improvement in the phase 3 study. Now this is the key study on the basis of which resmetirom got US FDA approval. This is the Maestro-NASH study, 245 sites across 15 countries, and the study design was doing a liver biopsy and a lot of other tests at the baseline. Week 16 MRPDFF was done. Week 24, the lipid markers were repeated, and at 52 weeks, which was the primary endpoint, the basic endpoints were reduction in the basic endpoints. So the primary endpoints was dual, as I mentioned earlier, as mandated by the US FDA, resolution of NASH, at least 2-point reduction in this NAS score without worsening of fibrosis, or reduction in fibrosis by 1 point without worsening of NAS. So these are the primary endpoint, the primary results of the primary endpoint in both the treatment arms, the 80 milligram and 100 milligram. This was a 1:1:1 randomization in placebo, 80 milligram and 100 milligram. And for both the primary endpoints, for both the doses, the results were significantly better as compared to the placebo, and there was no significant difference between the 80 milligram and the 100 milligram. And the subgroup analysis of the primary endpoint showed consistent results across the various stages of fibrosis, baseline activity, presence of diabetes, age or gender, and reduction in MRPDFF continued to be a predictor of response. The secondary endpoints in the form of lipids, ALT levels, MRPDFF, everything continued to improve, and the novel biomarkers, again, as in the previous 2 studies, continued to improve. The adverse events, again, in this study, the only adverse event to watch out is for diarrhea. Diarrhea is usually self-limited, described as a worsening of the pre-existing diarrhea, and the mean duration is quite small, is not more than 15 to 20 days. There was no drug-induced liver injury, there was no other thyroid hormone-related side effects, there was no derangement in the thyroid profile, and there was no bone-related side effects related to resmetirom. So if I show the initial slide which I had put up, and if I add resmetirom here, if you look at the studies, it improves the ALT-AST profile, it favorably affects the lipid profile, leads to improvement in steatosis. We have both biopsy-proven data and the non-invasive markers across 3 studies, good number of patients. It improves the inflammation, and in this study, if you look at it critically, they have used very stringent markers for NAS reduction, where you have to have at least 2 points reduction, and ballooning, which is the most important point, has to reduce to less than 1, so that is fulfilled here, and fibrosis also showed improvement more than 1. So what I want to say that currently, if it is available, this would obviously be the first available. There are a lot of other drugs, and this has got a novel mechanism of action where it acts directly on the liver, reduces liver fat production and reduces fibrosis also. This Maestro-NASH outcome is another trial which is to watch out for. Nearly 700 adults have been enrolled for this with compensated cirrhosis, and what they are looking at it as 5-year profile, what happens to these patients. So to conclude, resmetirom opens a new avenue for the treatment of MASLD. It has got an entirely different mechanism of action than all other drugs available. It has a good safety and efficacy and safety profile in phase 2 and trial, 3 studies. It has got beneficial cardiovascular effects, good safety profile. The long-term studies would be keenly awaited for. Thank you so much.
Excellent review. We are having new drug, novel drug, resmetirom, likely to come in our for our patients. And any questions from the floor? We should not forget that lifestyle modification is the main treatment of the fatty liver.
In US, it's $1,200.
And the cost of resmetirom, do you have any idea? 1 year cost of resmetirom, it is like 5 or 6 lakhs rupees. Let us wait. Let us wait for the new treatment. We should have lifestyle modifications and fewer indigenous drugs, saroglitazole, and waiting for the novel drug resmetirom. Thank you, Dr. Piyush.
I'd like to request Dr. Manohar Lal sir to kindly felicitate our chairperson, Dr. Ramesh Chandra sir. I'd like to call upon stage all the speakers, Dr. Piyush Ranjan sir, Dr. Neerav Goyal sir, and Dr. Hitendra Garg sir to please come upon the stage for felicitation. Thank you to the chairperson and the speakers for the wonderful session. Now I'd like to call upon stage Dr. Rajesh Agarwal sir, Dr. Sanjeet Saurav sir, Dr. Pranav Mandal sir, and Dr. Avinash sir to come upon the stage as chairpersons. I'd also request our speaker, Dr. Manoj Sahu sir, Senior Gastroenterologist, Odisha, to please come upon the stage to share on the topic H. pylori management in India.
Thank you, madam. Can I have my presentation? So, respected chairperson, seniors and friends, I am extremely grateful to the organizer for the opportunity. We will be speaking very briefly on Helicobacter pylori management in India. Helicobacter pylori is a etiological factor of peptic ulcer, gastric cancer, malt lymphoma, we know. It has also been associated with dyspepsia, and these are various studies from India, Association of Helicobacter pylori and dyspepsia. Functional dyspepsia and H. pylori eradication. Do you need to eradicate all our patients with functional dyspepsia? There is a RCT from Kashmir, showed non-significant response rate. There is also a meta-analysis of different RCTs with dyspepsia, non-noticeable benefit in most of the individual trials. So the current evidence from India is insufficient to recommend eradication therapy in dyspepsia. H. pylori, peptic ulcer disease, early gastric carcinoma, malt lymphoma. There is a beneficial effect. If you see the meta-analysis, beneficial effect of testing and treating this condition. This condition need to be tested and treated. GERD and Helicobacter pylori. There is an inverse relationship between H. pylori prevalence and occurrence of GERD. Suggests a protective role of Helicobacter pylori against GERD. H. pylori eradication does not cause GERD or influence response to therapy. In patients with GERD, routine testing for H. pylori, its treatment are not recommended. Long-term NSAID, when both are present, there is a meta-analysis, significant increased risk of peptic ulcer disease, odds ratio 61. It also increases the risk of bleeding in the tune of 6-fold. So testing of H. pylori and treating is recommended. H. pylori and ITP, unexplained iron deficiency, anemia and B12 deficiency. Studies from India have demonstrated response to iron is better when the organism is eradicated. A study from South India demonstrated positive effect of Helicobacter pylori eradication in improving idiopathic thrombocytopenic purpura. Reports of B12 deficiency in association with Helicobacter pylori. We do have some data, but the data appear to be conflicting. Helicobacter pylori in children with recurrent abdominal pain. Recent meta-analysis failed to establish an association between recurrent abdominal pain and Helicobacter pylori infection. So testing for H. pylori infection cannot be recommended for evaluation of functional abdominal pain in children. Testing of H. pylori should only be performed advised with gastric or duodenal ulcers. There is inadequate evidence in favor of a test and treat approach for H. pylori infection in children. 13C urea breath test has high sensitivity, specificity and excellent performance. The sensitivity, specificity and accuracy of stool antigen test is more than 95%. Serological tests, they have no role in H. pylori management. RUT has some sensitivity, specificity more than 95%. False negative results do happen in settings of recent GI bleed, recent use of antibiotics, PPI, or excessive gastric atrophy. Seth et al. In India demonstrated only enteral biopsy is associated with decreased sensitivity of RUT. We need to take at least 2 biopsy samples from corpus and enterum. Endoscopic Cato classification of Helicobacter pylori infection and gastric carcinoma risk diagnosis. It is the sum of 5 endoscopic findings: atrophy, intestinal metaplasia, enlarged falls, nodularity and diffuse redness. A score of 2 or more indicates H. pylori infection, 4 or more might indicate gastric carcinoma risk. We gradually, the society is now moving towards this enhanced endoscopy. So we can easily pick up Helicobacter pylori lesion endoscopically also without doing a RUT. Variable virulence strains and host genetic polymorphism documented to contribute the pathogenesis of Helicobacter pylori. We do have some information like cytochrome 2C19 IL1B polymorphism, but due to inconclusive results and absence of therapeutic implication, genetic studies are not recommended for clinical use at present in our country. Therapy of Helicobacter pylori eradication should be based on the current local antimicrobial resistance pattern if available. The goal of H. pylori therapy is to achieve eradication in 90 or more than 90% of patients who are treated. Duration of therapy. There are studies from India. Efficacy of 14 days is significantly better than 7 or 10 days. So 14 days for any kind of regimen, any kind of therapy, it is 14 days, not 10 days. Resistance of Helicobacter pylori to different antibiotics in India over last 10 years. You see different studies from different parts of our country and different antibiotics, but we should understand that the in vitro susceptibility results may not translate completely into in vivo sensitivity. Triple therapy. Increasing rate of H. pylori resistance to clarithromycin and metronidazole, so which is diminishing the efficacy of PPI based triple therapy. High imidazole resistance like imidazole based triple therapy, metronidazole or tinidazole or any imidazole should not be used for eradication of Helicobacter pylori in India. Efficacy of standard triple therapy. There are many studies from different parts of the country. But if you see study from Patna, 58% is significantly low. So if there is high clarithromycin resistance, what should be the second line treatment? There is a meta-analysis. You see, if you are using quadruple therapy like bismuth quadruple therapy, eradication rate is great, is very good. Quadruple regimen, instead of metronidazole, you can start amoxicillin also. This eradication rate is significantly better. So bismuth bed quadruple therapy should be the second line of therapy in our country. So sometimes we might think that tetracycline is not available. Can we substitute doxycycline in place of tetracycline? But the study is showing less efficacious. Doxycycline is not recommended as a substitution for tetracycline in this regimen. This is the study comparing vonoprazan triple dual therapy with PPI triple therapy. If you see the first right side, there is no resistance of clarithromycin, amoxicillin. So this vonoprazan dual and triple therapy is non-inferior to PPI triple therapy. And if there is clarithromycin resistance, it is superior. And if you see the extreme right, the superiority in all patients, vonoprazan triple therapy is superior. Failure of second line therapy. Second line therapy fails now. Levofloxacin, the amoxicillin PPI at the third line treatment regimen, you see the eradication rate. Even if patient failed to PCA, failed to bismuth quadruple therapy in the tune of 85%. So that if there is a failure of a non-bismuth quadruple therapy, we always consider a bismuth quadruple therapy. Eradication rate is pretty good. Concomitant therapy is preferred than sequential therapy. So we should consider concomitant therapy, not sequential therapy in this scenario. Hybrid therapy is another alternative in first and second line treatment failure. This is Argentina. This is a beautiful, very recent study why I put here, because this is the national registry. So what they have demonstrated, first line treatment in treatment naive patient, bismuth quadruple, bismuth concomitant, this eradication rate is very good. Also the same thing they have replicated in the second line treatment also. This is the most recent study across the world, published just last month, SEG clinical practice guideline. If you see, they have recommended in treatment naive patients, bismuth quadruple should be the first line therapy. And rifabutin triple therapy, vonoprazan dual therapy, also they have suggested as other regimen, treatment naive patient. Or treatment naive is bismuth quadruple. And who have experienced treatment and failed, they have suggested again bismuth quadruple and rifabutin triple therapy. This is the most recent publication by ACG. Post-treatment testing for cure should be advised in every patient whom you are treating. And we can assess with urea breath test or stool antigen test. Antimicrobial peptides and Helicobacter pylori. Antimicrobial peptides, as we know, are small peptides that are part of innate immune system. We have identified 9 groups, 22 antimicrobial peptides which have demonstrated anti-H. pylori effect. So in presence of increasing resistance to antibiotic, antimicrobial peptide might have the potential to replace the antibiotic. We can combine with antibiotic or we can use antimicrobial peptides alone in eradication of Helicobacter pylori. Probiotic and Helicobacter pylori. In a meta-analysis 534 RCTs improved eradication rate and reduced adverse reaction when you are combining a probiotic with the regimen. Single strain or multiple strain preparation of probiotic supplemental saw similar results, but there is insufficient data, insufficient evidence that probiotic therapy improves efficacy and tolerability. So in our country, it should not be advised in every prescription, including the very recent guideline from ACG. They have told the same thing. H. pylori gastric carcinoma prevention, an Indian enigma. Very high prevalence of H. pylori infection in our country, but low frequency of gastric carcinoma. If you see two center study from Lucknow and Calcutta, 279 patients with gastric neoplasm, they failed to show higher frequency of Helicobacter pylori. So due to low frequency of GC in Indian population, routine H. pylori eradication to prevent the gastric carcinoma should not be recommended, cannot be recommended. H. pylori and pre-neoplastic lesion. A significant observation, H. pylori eradication heals chronic active gastritis and reverses gastric atrophy. It cannot reverse intestinal metaplasia, but we have good evidence it halts the progression of intestinal metaplasia. Patients with adenomas and hyperplastic polyps not in fundus in the body and antrum often have associated with gastric pre-malignant condition. This is a very recent data, recent information from the American Society. What they are telling, adenomas and hyperplastic polyp in the body and antrum, they are usually associated with gastric pre-malignant condition. These patients need to be tested and treated, eradicated. Those who are at increased risk of gastric carcinoma like corpus predominant gastritis, gastric atrophy, intestinal metaplasia, adenoma, hyperplastic polyp, not in fundus, family history of gastric carcinoma should be tested and treated. H. pylori testing and treatment in all patients diagnosed with autoimmune gastritis are recommended. This is the information, we have good data now. This is the information from ACG that patients who are diagnosed with autoimmune gastritis, their pre-malignant condition, they can progress to gastric atrophy. They are usually associated with the Helicobacter pylori infection in our country. Some data we have, so the testing and treatment should be recommended. Antibiotic resistance profiling. Culture is cumbersome. Molecular methods expected to dominate the field shortly. Next generation sequencing, NGS, overcome the need of culture, evaluate all possible mutation and underlying resistance to multiple microbial simultaneously. So profiling of H. pylori resistance by NGS from stool samples can be done, which obviate the need of endoscopy and biopsy. H. pylori vaccine, we do not have great information, good data for a vaccine as of now, but the research is going on. Current evidence from India is insufficient to recommend eradication therapy in dyspepsia. The choice of the regime to be used would depend on the local resistance pattern. It is important that periodic resistance pattern is evaluated in different regions of India by ICMR and should be communicated to us. Salvage therapies include standard triple therapy that have not been previously used, bismuth-based quadruple therapy, levofloxacin based therapy or rifabutin based triple therapy. Levofloxacin resistance is high in America, USA, but in India we are in the better condition as considered levofloxacin. Molecular based susceptibility profiling facilitates selection of a personalized eradication regimen. The availability of PK based therapy also likely to improve treatment success. Probably we might need to consider bismuth quadruple therapy at the first line regimen. Our national guideline was formulated in the year 2021. It is 3 years now. I think we need to revise our national guideline. Every effort should be made to develop a national registry to track H. pylori antibiotic resistance and local eradication success rate. The national registry already started. It will be communicated to all members. Truly novel therapies are needed, including vaccines. Due to incompatibility implication, genetic studies are not recommended for clinical use in our country at present. There is an urgent need for the involvement of the pharmaceutical industry to be proactive and spearhead research in the field of H. pylori treatment. Thank you very much.
Very nice talk, sir. Any question from the house? No. But if you are doing an endoscopy, you should have some indication in dyspepsia. In a patient of dyspepsia, if you are doing endoscopy, and during endoscopy, if you are finding some pre-malignant lesion, so you can consider testing and treatment. Otherwise, if endoscopy normal, no need to test and treat. Yes, definitely. So we also change our practice. So one biopsy from the antrum, other biopsy from the corpus. So because we have evidence now from India, outside India also, if you are taking one biopsy from the antrum, the sensitivity decreases. So you have to take 2 pieces sample and use the same thing what you are using routinely.
So one question from my side. We use RUT test for rapid urease kit test for detecting H. pylori infection, but most of the patients who come to us are already on PPIs. So there might be a high possibility of false negative RUT test. So for how many hours we should wait for the kit to change? Because some of the kits change color after 12 hours, 24 hours. If the patient is on PPI, so we should consider that if the color has changed after 24 hours, that should be positive, should be taken as positive or negative.
So the recommendation is, evidence is, whatever test you are doing, it is invasive, non-invasive, serological, RUT, biopsy, PPI should be off at least for 2 weeks. But if a patient is on H2 receptor or antacid, no need. So it does not influence, he can do the test immediately. But PPI should be stored for 2 weeks. But you are asking how much time we should wait. Because the clinical practice, you should see the recommendation of the company. So in our practice, we wait for 1 hour only. If it is more than 1 hour, no need to consider that it is positive.
We should move. Any other question?
Thank you very much.
Thank you, sir. Now I would like to invite our next speaker, Dr. Sanjeev Kumar Verma, sir, Senior Consultant Gastroenterologist, Patna. He will be speaking on the topic endoscopic management of typical CBD stones. would like to invite Dr. Sandeep Pal sir, Senior Consultant Gastroenterologist, RN Tagore Hospital, Calcutta. He will be speaking on the topic endotherapy in pancreatic disease.
Good evening. First of all, I would like to thank the organizers for this invitation. So my topic is endoscopic therapy in chronic pancreatitis. Now there is a lot of debate about this, whether should we do endoscopy in chronic pancreatitis or should we give it to the surgeons. So in my talk I will highlight like what are the indications where endoscopic therapy might help and when we should hand over it to the surgeons. So as you know, chronic pancreatitis is an irreversible condition, inflammation of the pancreas, and it is characterized by fibrosis, sometimes stricture of the duct, and also stone formation in the pancreas. Maybe there can be parenchymal calcification as well as ductal calcification. And pain is the most important clinical problem which occurs in 80 to 90% of patients and can be associated with endocrine and exocrine insufficiency. Now if you see this picture, this is how a chronic pancreatitis looks like. In the left-hand X-ray picture, you can see the conglomeration of the stones in the head and the neck region of the pancreas, whereas in this pancreatogram, you can see the stone which is there in the head of the pancreas. Now the mechanism of pain in chronic pancreatitis is not simple, it's very complicated. There are various mechanisms which can explain the pain in chronic pancreatitis, out of which there is ductal or interstitial hypertension, there is local oxidative stress, local inflammation, there is nociception, then there is something called pancreatic neuropathy, neuroplasticity, and of course the central neuroplasticity. Now if we do endoscopic therapy or surgical therapy, what we can take care is only of the ductal or interstitial hypertension. We cannot do anything about this. So when we do any procedure in these patients, what we should clearly tell our patients is that maybe there can be some decrease in the pain, but you cannot guarantee the patient that if I do this procedure, there won't be any more pain. So these things should be kept in mind while counseling these patients. Now for endoscopic therapy, what is the aim of endoscopic therapy? So the aim of endoscopic therapy is to relieve the obstruction of the pancreatic duct and to reduce pressure. This is the only thing that we can do, and we can do this by doing a pancreatic sphincterotomy. We can remove the stone if there is in the pancreatic duct with or without ESWL. If there is a stricture, you can do a pancreatic stricture dilatation and place some pancreatic stents. Now, so in the duct, there can be two things, as I told. One can be calculi or another can be stricture. Now, this management of pancreatic stones, it is present almost in 60% of patients, more in men who has got a history of alcohol intake, typically more than 80 grams per day and more than 20 cigarettes per day. And according to the guidelines, for stones less than 5 millimeter, we can straight go ahead with an ERCP and sphincterotomy and cause stone extraction. Whereas if the stones are bigger than size 5 millimeter, then I will come to those. What are the next things if you do if their stones are bigger size. So at the same time, after doing sphincterotomy, dilation, balloon, basket retrieval is often sufficient for smaller stones. So this is a typical procedure, pancreatic ERCP. So you do a cannulation. This video is not playing. Let me try. Anyway. The video is not playing, sorry for that. So this is not a very difficult procedure. All of us do pancreatic ERCP, so I will skip this. So the guidelines are for management of pancreatic stones, ESWL plus ERCP. For radiopaque stones, as I said, if you are more than 5 millimeter, if it is less than 5 millimeter, then you can straightly go ahead with ERCP. But if the radio-opaque stones are more than 5 millimeter in size, then ESWL is done, which should be followed by ERCP. This is how a ESWL setup is. This is how a ESWL setup is there. Like successful stone fragmentation following ESWL, stones are broken into fragments, typically less than 2 to 3 millimeter, and that can come out. The fragments can come out spontaneously, or sometimes it has to be followed by ERCP. So pre-ESWL, this is how the stone looks like in the head and the neck region of the pancreas, whereas after ESWL, this you can see the X-ray in this, that part is cleared. So this can be spontaneously cleared, or sometimes you need to do ERCP. So this was another video, but these videos are not playing here, I'm sorry for that. So this was a, we could have shown you like how after ESWL it looks like simple like powder, like white powder which comes out of the pancreatic duct if you cannulate the pancreatic duct here. So for management of pancreatic stones, again there are large number of studies available in the literature, but the most important and the biggest study is from India, that is from AIG. The study, this has almost, they have published this study with 5,000 patients with a complete clearance of around 73% and pain relief in 82% of patients, and the follow-up was for a period of 6 months. So in that study, Dr. Manu Tandon et al. Has reported that ESWL is highly effective at stone fragmentation, and subsequent complete clearance of the PD by ERCP is achievable in more than 2/3. And more than 1/2 of the patients treated in this way remain pain-free over a 2-year interval, and up to 89% report significant improvement in quality of life. And in that paper, they have said that the patients who had this pancreatic calculi, the etiology most common was idiopathic, and in most of the cases, multiple stones were present. And the number of ESWL sessions that were required were 3 on an average. If you do 3 sessions of ESWL, then you can clear most of the duct. That they have reported in around 73% of the patients, and the complete clearance, as I said, was around 72 to 73% of the patients. And all these patients required a pancreatic sphincterotomy. If you are almost more than 3,000 patients, they had done pancreatic ductal stenting, and around 22% of the patients had associated strictures. This is another study in which they have shown the success of ESWL and ERCP in symptomatic PD stones. This is a systemic review and meta-analysis of almost 4,000 patients. Here also they have shown a complete ductal clearance of around 70% and complete absence of pain during follow-up in around 65%. So next, after ESWL, now this ESWL is a bit complicated, like you require a separate set of machines. Sometimes you might share with your urologist. So we don't have, in my hospital, I don't have ESWL. So what I do is I do EHL. So again, the video is not playing. So EHL is the same thing. Most of us, we have a cholangioscope with us. So if the duct dilatation is there, and if the duct dilatation is more than 10 millimeter, what you can do is you can cannulate the pancreatic duct. You can do a good sphincterotomy, and after sphincterotomy, you can introduce the cholangioscope into the pancreatic duct, and you can directly break the stones into smaller pieces, and you can clear the PD. So the advantage of this pancreatoscopy, EHL or laser lithotripsy, both have got same efficacy. There is increased availability. It's more available than your ESWL machine. Only 1 session is required, and there is no dependency on urology or other units. So this is another study reported in World Journal of Gastroenterology, in which they have almost reported 400 patients, and the technical and clinical success were almost more than 70%, and adverse events were also very less. And in this study, they have shown that the laser lithotripsy and EHL, there was no difference in the outcome. And the success, this was a very heterogeneous population, mostly retrospective data, but they have shown that a good success can be achieved with this procedure. So the factors which independently associate with long-term pain relief after endoscopic therapy is if the stones are in the head. Suppose if the stones are in the tail or in the body, it's difficult to clear when comparison to stones in the head. If the patient has got a short disease duration, low frequency of pain attacks, complete MPD stone clearance, absence of MPD stricture, and discontinuation of alcohol and smoking. So these are the factors which influences the pain relief. So this is the same thing which we have discussed. The ASG also, the American Society of Gastrointestinal Endoscopy also, they also recommend the same thing for stones which are more than 5 millimeter. ERCP with ESWL is recommended for if the stones are less than 5 millimeter, you can go ahead with ERCP. If not, ESWL also can be done in those patients. Now coming to the next topic, that is chronic pancreatitis with PD stricture. So dominant PD stricture is defined as an upstream dilatation of the PD of more than 6 millimeter. For dominant MPD stricture, a single 10 French plastic stent is recommended. Multiple PD stents can be applied, but I'll show you a study, retrospective study, where they have shown that in comparison to multiple PD stents, single PD stent is better. That I will come to that study, and the technical success of PD stenting is almost more than 98%. So these are the again two videos, this won't play, so I'll skip this. So these are the various studies where plastic stents were used for MPD strictures, and as you can see, the follow-up period ranges from 44 months to 173 months. Pain relief is almost up to 90%. Surgery is required only in 1 to 26% of patients, and in almost 80% of the patients, no further interventions are required after stenting the pancreatic duct. So pain relief is up to the tune of 90%. Now, when we place plastic stents, sometimes there is something called metallic stents also for PD strictures. So this self-expanding metallic stent for refractive pancreatic duct strictures in chronic pancreatitis, this is a prospective follow-up study where they have shown that when you place metallic stents, the pain score is better. If you see the pain score, they have compared pre-SEMS in comparison to the post-SEMS, the VAS score is lesser in patients who had been stented with pancreatic stents. Now this is a very interesting study. Normally what we think is, if we place multiple stents, at least in the case of biliary stents, if you place multiple stents, the stricture dilatation is better. But in case of pancreatic stents, this retrospective study has shown that single stent is better than multiple stents, because of the reason that if you place multiple stents in the pancreatic duct, there is more duct damage, there is injury to the duct, and these patients this might induce further pancreatitis. So what size of stent should we apply in MPD structures? The studies have shown that a 10 French stent, the bigger the stent, it's better than when you compare between fully covered and plastic stent. The study has shown that the fully covered stents are better in comparison to ERCPs because they require fewer number of procedures. So the number of stents, single stent is preferred, stent diameter 10 French is preferred, and routine use of fully covered stents for patients with a persistent or refractory PD structure who have failed initial stent placement. Now celiac plexus block, should we do this celiac plexus block in chronic pancreatitis? Yes, sometimes you can do in patients who have small duct disease. If you have no options left, only in those group of patients celiac plexus block can help. So this was a study again which compared percutaneous fluoro-guided celiac plexus block in comparison to US guided celiac plexus block, and it clearly showed that the US guided celiac plexus block is better than percutaneous fluoro-guided US block for pain amelioration in patients of chronic pancreatitis. So now coming to the next thing, sometimes due to chronic pancreatitis, biliary strictures will form. Now in these biliary strictures, we know multiple plastic stents can be, the study by Costa Magna had shown that multiple biliary strictures are better than single stents for these biliary strictures. So now this is a study mostly from AIG, and they have shown that they had compared fully covered self-expanding metal stent versus multiple plastic stents to treat benign biliary strictures, and this study have shown that the efficacy of plastic stents and metal stents are almost same. Only advantage is the number of ERCPs. So the number of ERCPs required when you place a metallic stent is less. So after this, the recommendation is endotherapy of chronic pancreatitis associated benign biliary stricture has similar efficacy and safety for 12 months using multiple plastic stents compared with a single fully covered stents, and the recommendation is to use the fully covered stents and not the multiple plastic stents. And based on this, the AIG suggests fully covered stents over multiple plastic stents for treatment of benign biliary strictures completing chronic pancreatitis. Now coming to surgery versus endotherapy. So this was a study, but this is a Cochrane review where they compared surgery versus endotherapy for pain in chronic pancreatitis patients. And this Cochrane review has clearly shown that the pain relief is better in surgery when compared to endoscopy. So if you can see this diagram forest plot, you can see here, of course, for pain relief, surgery is better than endoscopy. So the conclusion was surgery is superior to endoscopy for pain relief. But only thing is, sometimes there can be more complications, morbidity and mortality is more for surgery. So you have to carefully select the patients, and as endoscopy can cause less complication and mortality as well as morbidity in endoscopy is of course lesser than surgery. Only thing with endoscopy is you require multiple procedures, while surgery is a one-time solution. This is another study, the ESCAPE trial, which was published in JAMA in 2020, when this also again compared the pain relief between surgery, early surgery and endoscopy group. Again, this showed advantage of surgery over endoscopy in pain relief. So this is in a nutshell, this is my last slide. In chronic pancreatitis patients, what you do is you see that whether the ducts are dilated. This is a paper by Dr. Nageshwar Reddy, where they have shown if the ducts are dilated, if there is a single stone, if there are multiple stones, you go ahead with ESWL. If there are single stones, small size, less than 5 mm, do endotherapy. If the duct is dilated and there is an associated pancreatic head mass, surgery is the first option. If the patient has non-dilated ducts and there is pain, sometimes medical therapy, celiac ganglion block can be done. And if there are complications, then sometimes you do a US guided drainage and all this, there are multiple procedures can be done. So the take-home messages are for pancreatic stones less than 5 mm ERCP, more than 5 mm you can do pancreatoscopy or ESWL. For pancreatic duct stricture, larger plastic stents while avoiding fully covered SEMs. For celiac plexus block, US may be preferred over percutaneous approach. For biliary stricture secondary to chronic pancreatitis, use fully covered SEMs. Endoscopy initial therapy for carefully selected group of patients, and surgery without prior endotherapy in a subgroup, multiple strictures, stones, especially body and tail. These are the subgroup of patients which should be given to the surgeons if there are multiple strictures and if the stones are in the body and the tail. And surgery is of course more effective than endotherapy for long-term pain relief. Thank you.
Thank you, sir. Very informative talk on endoscopic management of chronic pancreatitis. Any question from the house?
Yes.
Sir, a young 16-17-year-old, he has underwent 3 sessions of ERCP till now with pancreatic sphincterotomy. One dominant stricture with a stone, upstream stone, single stone, not very dilated duct. Till now 7 French stent we could place. CRE 1 session 8 mm we could do, but there was no obliteration of the waist. Every time the stent slips, he has a mild pancreatitis. Never had a very severe pancreatitis. In this kind of patients, how many times to place a stent?
So if these are refractory strictures like with plastic, you can try metal stent, bumpy stent. That is a metal stent. That will cause better resolution of the stricture. Thereafter, the stone might come out, or the patient, you can subject the patient to ESWL, because if there are strictures, I won't advise this cholangioscopy. Pancreatoscopy will be difficult to do, because for pancreatoscopy you need a good duct dilatation, because that is itself 10 French, the diameter of the pancreatoscope, cholangioscope. So this patient, if the patient like the stricture dilatation is not adequate, then if there are multiple strictures, I will advise surgery. But if there are single strictures, still you can try endotherapy and cause a duct dilation. Interestingly, in pancreatic cases, multiple plastic stents are not recommended. That we should remember.
So for next session, what to do for dilatation? CRE or?
CRE, you can do a CRE dilatation. 8 mm you already have tried. Or after that, you can place a metal stent. Bumpy metal stent.
How long is bumpy?
Up to 1 year you can keep. The studies have shown up to 1 year.
Thank you, sir. Thank you very much.
Thank you.
Thank you, sir. Now I would like to invite our next speaker, Dr. Sanjay Singh sir, Senior Consultant Gastroenterologist, Asharafi Hospital, Dhanbad. He'll be speaking on the topic GERD.
Good evening, everyone. I am Dr. Sanjay Kumar Singh, working as a consultant gastroenterologist at Asharafi Hospital, Dhanbad. Thank you, first of all, to the organizing team, Dr. Ravish, Dr. Saurav, Dr. Chandan, and giving me the opportunity to give a talk on this common topic, which is we frequently encounter in day-to-day practice. So, our brief outline of the topic would be introduction, pathogenesis, diagnosis and management, current treatment options according to ACG guidelines 2021, ICG statement on the GERD management. So what is GERD? We have got two entities. One is GER, that is gastroesophageal reflux, and other is gastroesophageal reflux disease. Gastroesophageal reflux is a common entity that we frequently encounter in normal individuals that is not associated with symptoms, or there is no evidence of any endoscopic evidence of mucosal damage. While GERD is gastroesophageal reflux disorder, is a medical condition that arises when the backflow of stomach content results in emergence of unpleasant symptoms and or complications. Coming to the disease burden, it approximately affects 10 to 20% of the adults, and it is higher prevalent in males compared to the females. In India, there are various studies that shows that there was different prevalence in different parts of the country. Suppose like in Delhi, it was 16.2% in selected population. In Lucknow, it was 11%, while in southern part, it was in Chennai, it was 28.5%, while in Vellore, it was 8.2% in urban population. What are the detrimental effects of GERD? It causes significant morbidity, work absenteeism, impaired quality of life, may lead to complications like peptic stricture, Barrett's esophagus, and adenocarcinoma. Coming to the risk factors, it was found that age per se is not a well-documented risk factor as per the pooled prevalence. With increasing age, there was no increase in the prevalence of GERD. And along with that, alcohol intake was also not found to be significantly associated with the prevalence of GERD. But body mass index was found to be significantly associated with the prevalence of GERD. Body mass index less than 18.5% had got a pooled prevalence of gastroesophageal reflux disease of 6.64%, whereas if it is more than 30 kg per meter square, it was the prevalence of GERD had increased up to 22.63%. Similarly, NSAID users or aspirin users have got higher pooled prevalence of GERD. Briefly about the pathophysiology of GERD, as most of the people know, there is offensive and defensive forces that prevent the GERD. The defensive forces are the His angle, tone and function of lower esophageal sphincter, hiatus hernia, transient lower esophageal sphincter relaxation. The other factors that contributes or that mechanism that leads to development of GERD are motor abnormality of lower esophageal sphincter, that is LES, transient lower esophageal sphincter relaxation, impaired esophageal acid clearance, that is, it was found that GERD patients has got persistent acid clearance time that was 2 to 3 times longer than those of subject without GERD. There was delayed gastric emptying which was found in patient with GERD, and hiatus hernia was found to increase the chronicity of GERD by hindering the LES functions. It also acts as a reservoir. Visual sensitivity was found to be higher in patients with GERD compared to the normal individuals. There was impaired mucosal resistance in GERD patients that leads to increased intracellular permeability in the esophagus. These are the factors that affects the lower esophageal sphincter tone. There we can see the protein among the food part increases the LES pressure, while fat, chocolate, peppermint can decrease the lower esophageal sphincter pressure. And among the drugs, antacids, domperidone, baclofen, cisapride, metoclopramide are found to increase the LES pressure, while mepridine, morphine, theophylline, serotonin, these are found to decrease the LES pressure. Now coming to typical symptoms, heartburn is the most common symptoms that may be daytime or it may be nighttime. Regurgitation is the reflux of high volume content into the food pipe, and water brush, that is hypersalivation. Coming to atypical symptoms, nausea, irritation, slow digestion or early satiety is a feature. Along with that, many patients may present with bloating, vomiting, chest pain, that is precordial, respiratory symptoms like cough, wheeze, chronic rhinosinusitis, some ENT related symptoms like hoarseness, pharyngeal pain, globus, that is feeling of something stuck in the throat, early awakening, nocturnal awakening or nightmares. So broadly, GERD has been classified into two types based on endoscopy. It may be either evidence of mucosal damage, that is called erosive reflux disease or reflux esophagitis, or if there is no evidence of erosion on endoscopy, it is called non-erosive reflux disease, that is called NERD. NERD or non-erosive reflux disease is by far the most common form of GERD globally. The severity of GERD is classified according to Los Angeles system or LA system. Here we can see the 4 types of patterns are there that we have frequently encountered in our day-to-day practice. That is, the first one is the A type, which has got less than 5 millimeter mucosal break in the endoscopy at the lower esophageal junction, and more than 5 millimeter mucosal break is called type B or LA grade B. LA grade C involves less than 75% of the esophageal circumference, while LA grade D involves more than 75% of the esophageal circumference. Now coming to the symptom and approach to evaluation of GERD. This is an important slide that I would like to your attention. If the patient is having troublesome symptoms that are suspicious of GERD, and that is typically heartburn, regurgitation or esophageal chest pain, then initial approach will be to start empirical trial of anti-secretory agents like H2 receptor antagonist or proton pump inhibitors if there is no alarm symptoms. If the patient has responded to it, then we can stop the treatment after 8 weeks, and if the patient has not responded to it, then we can proceed further for endoscopy, wireless pH monitoring or pH impedance monitoring or high resolution monitoring. Adjunctive therapy should be tried in case the patient is having rumination, then behavioral therapy is recommended. The patient with atypical symptoms like belching, chronic cough, asthma, hoarseness of voice, globus, nausea or abdominal pain, in these cases we can directly proceed with endoscopy, and provided we have done the previous workup. Suppose in case of chronic asthma or cough, we should do the pulmonary evaluation first. Patient with symptoms related to throat, we should do the ENT evaluation for laryngoscopy first, and if that is inconclusive and that has not responded to that treatment, then we should look for GERD as a possible cause. In that case, endoscopy, pH impedance monitoring or wireless pH monitoring should be done. So this is the current guideline according to ACG, American College of Gastroenterology. For patient with classical GERD symptoms, that is heartburn or regurgitation with no alarm symptoms, it is recommended to prescribe 8 weeks PPI once daily treatment before meals. And if the patient has responded well to the treatment, then we have to discontinue the PPI in whom that classical GERD symptom has responded to 8 weeks empirical trial of PPI. And if it has not responded to 8 weeks trial of PPI, then we have to perform endoscopy, ideally after PPI has stopped for 2 to 4 weeks in patient in whom the GERD symptoms does not respond adequately to that treatment. Secondly, if the patient who has chest pain without heartburn or who had adequate evaluation of heart disease and it has been ruled out to have any heart disease, then GERD testing will be done by doing endoscopy and or reflux monitoring. Coming to barium swallow is not recommended as a sole diagnostic test for GERD, and because it has not got any conclusive role. In cases, it is to be done in cases where we are suspecting any stricture or in dysphagia. Endoscopy is recommended as the first test to evaluate any patient with alarm symptoms like dysphagia, weight loss or GI bleed, and in patient with multiple risk factors for Barrett's esophagus. We should perform reflux monitoring in patients in whom the diagnosis of GERD is suspected but not clear, and endoscopy is showing no evidence of gastroesophageal reflux disease. The pH monitoring or reflux monitoring is not recommended to perform reflux episode, as only to diagnose GERD in patient in whom we have already diagnosed endoscopically it has got grade C or D esophagitis or long segment Barrett's esophagus. Long segment means more than 3 centimeter. In those cases, we need not do reflux monitoring. So these are the battery of tests that has got different level of evidence. We can see that in the first, the PPI trial has got the maximum level of evidence, that is meta-analysis, particularly in classical symptoms with no warning signs. Barium salve has got no use. Endoscopy in cases with alarm symptoms. Endoscopic esophageal biopsy should be done in those cases which we want to rule out other causes like eosinophilic esophagitis. Esophageal manometry should be done in those cases in which that we have to rule out other causes like echalasia. Ambulatory reflux monitoring is an ideal test to be done in which we have got endoscopy done, but we have no any evidence of erosion, but we have got strong suspicion of gastroesophageal reflux disease. These are the indication of endoscopy. It should be done irrespective of age, new onset upper GI symptoms, alarm symptoms, and it is the easiest test to distinguish erosive esophagitis from non-erosive reflux disease. In cases, the esophageal manometry should be done in cases where the endoscopy is negative and the patient is unresponsive to PPI therapy to rule out motility disorders. In case of preoperative evaluation and for the location of pH probe. And it is ideally recommended in condition where suspecting echalasia or scleroderma preoperatively. So this is a figure in this 24-hour pH monitoring by putting a nasal catheter. It is a physiological study. The parameter which we check in reflux monitoring is percentage of time the pH is going less than 4 and the Demister scores. The Demister score has got 6 variables in which the number of reflex episodes, the maximum reflex episode, and the times of reflex the pH is going less than 4. Coming to the other part is symptom correlation. That means when the symptom is happening, that time whether the reflex is happening or not. That way we have to correlate. Another is acid exposure time. How much time the acid is coming in contact with the lower part of the esophagus. So this is a brief slide that we can see the first part, that is if the patient is having LA grade C or D esophagitis, long segment Barrett's esophagus, acid exposure time, that is AET more than 6%, that it has got conclusive evidence of pathological reflux. Some areas where there is inconclusive evidence or supportive evidence are in case of LA grade A or B esophagitis, where the acid exposure time is 4 to 6% and reflux episode is 40 to 80 frequency. And the evidence against pathological reflux is if the patient is having acid exposure time less than 4% and the reflux episodes are less than 40 times. So this is the slide. In this case we can see the normal person has got less frequent times the pH is going less than 4, while in case of GERD patient the frequency is higher and it has got duration of the pH going less than 4 is longer. The wireless catheter based esophageal pH monitoring, that is the Bravo pH monitor, is preferred because it has got better compliance and it can be used for a longer period for pH studies. The treatment goal of GERD is to eliminate symptoms, heal esophagitis, manage or prevent complication, maintain remission. The non-pharmacological management like weight loss is the most important. Along with that, we should avoid caffeinated beverages or coffee, and other like pharmacological treatment we should start. In this the lifestyle modification is very important. We have to advise every patient who are having suspicion of GERD, elevation of head end of the bed, lying in the left lateral decubitus is found to be beneficial in case of GERD patient. Avoiding the consumption of meals 2 to 3 hours before meals, and wear loosely fitted garments. It was found that losing weight itself less than 3.5% BMI has been found to be reducing the GERD symptoms up to 40%. Coming to pharmacological intervention, the medical management is available as antacids, surface agents like alginates, H2 receptor antagonists, and PPIs. The newer molecule for this is potassium competitive acid blocker. We have got several talk regarding this, and I'll just briefly tell about this. It has got faster onset of action. It is non-inferior to PPI to heal esophagitis, and it may heal esophagitis and reduce symptoms in patients who fail to respond to PPI therapy. Contrary to PPI, elimination of PCAB is independent of cytochrome P2C19, and this explains a stronger effect of PCAB on acid suppression among Asians. So these are the ideal dose of vonoprazan, that is the PCAB, and what are the indications that we can see here: gastric ulcer, duodenal ulcer, reflux esophagitis, healing, maintenance, adjunct to H. pylori treatment. These are the newer molecules for coming. Where the reflux is not responding to medical treatment, then we can think of surgery or other devices like magnetic sphincter augmentation device. Now coming to the last slide of my topic, this is the current algorithm for management of GERD as per the ISG Consensus Guideline 2019. If the patient is having heartburn or sore regurgitation, no alarm symptoms, we should first start with lifestyle modification, as I told, weight loss and avoiding the high calorie foods and coffee. If the patient is having mild or occasional symptoms, on demand H2 receptor antagonist or antacid should be given. If the patient is having response, then we can leave on follow-up. If we can do long-term management by either maintenance or on-demand therapy or reducing the dose, or we can completely stop if the symptoms are elevated. If we can reassess the indication for PPI periodically in long-term users, give lowest possible dose, attempt to taper or stop PPI wherever feasible. In other cases, if the patient is having severe or frequent symptoms, PPI once daily should be given. If there is no response, then PPI dose optimization. We can be giving twice daily dose. If there is no relief, then we can go for endoscopy. Endoscopy may be either normal endoscopy, it can be esophageal reflux disease or esophagitis. In that case, we can continue PPI for a longer period. And if there is alternative diagnosis like eosinophilic esophagitis or achalasia cardia, then we can treat accordingly. And if the patient is not having esophagitis, we have given a PPI double dose for 8 weeks, still it has not responded, then we can do the 24-hour pH impedance monitoring. It can be two, either it will be confirmed reflux, then we can continue with PPI therapy. If it is not working well, then we can go for endoscopic or surgical intervention, and we can add PPI or addition H2 receptor antagonist as per need. And we can add prokinetics in patient with high volume reflux. If the patient is having unconfirmed reflux, like the pH is not going less than 4 and the patient is having symptoms, then we have to see the association, whether the symptoms are associated with the reflux or not. If the symptoms are associated with reflux, but the pH acid exposure time is not adequate to classify as a reflux, then it can be reflux hypersensitivity. In that case, we can add tricyclic antidepressants or SSRIs. If the patient is having reflux episode, but the symptoms are not associated and the pH is also not going less than 4, or it is pH is going more than 4, then in that case it can be heartburn. In that case, the psychiatric evaluation can be required. I would conclude with my slide, and I'll be happy to answer any questions. Thank you.
Any questions?
Thank you.
I'd request our chairperson to felicitate our speakers. Dr. Manoj Sahu sir, Dr. Sanjay Singh sir, Dr. Sandeep Pal sir. Now I'd request Dr. Satbir sir and Dr. Ravish sir to please come up on the stage as chairpersons.
Now I would like to invite our next speaker, Dr. Anirudh Bandyopadhyay sir, HOD Bokaro General Hospital, to come on the stage. He will be speaking on the topic obscure GI bleeding.
Revered senior gastroenterologists and residents. Today the topic of discussion is obscure GI bleed. Time is running very short, so I complete the lecture fast. Thank Dr. Jayant Ghosh for giving me this opportunity. First, coming to the definition of obscure GI bleed, it is the bleeding that persists or occurs after a negative initial or primary endoscopy. It constitutes 10% of all GI bleeds. Obscure GI bleed can be occurred or it can be overt. Occult GI bleed is reserved for patients presenting with unexplained iron deficiency anemia and or fecal occult blood positivity. Overt GI blood refers to cases presenting with melena, hematomesis or hematochezia. Etiologies, coming to the vascular etiologies, angiectasia is very common, Delafoy lesion, GAVE, varices, small varices, esophageal, gastric, small bowel, and hemorrhoids. Ulcerative causes, they are very common in Indian subcontinent. NSAIDs, Crohn's, TB, peptic ulcer disease, esophagitis, and Cameron erosions. Neoplastic causes are benign polyps, adenocarcinoma, carcinoid lymphoma, small bowel CA, cyst, and metastasis. Infective causes are common in India, rare in Western countries. Tuberculosis, enteric fever is resurging, and amoebiasis. Diverticular causes are Meckel's and diverticulosis. Other rare causes are there like von Willebrand and blue rubber bleb syndrome. The incidence varies from 5 to 10% of all hospital admissions. A majority of them are small bowel lesions, 75%. You have to take a look at history before jumping into the higher diagnostic modalities. Patient is of young age with intermittent bleeding, Meckel's should be thought. If the middle-aged patient with epigastric pain with aspirin use, then PUD would be thought of. Chronic periumbilical pain with aspirin use or lower umbilical pain with aspirin. Ulcers may be in the colon or in the ileum. If there is pain, abdomen, fever, and bleed, then we could think of enteric. If there is cramping pain with bloody diarrhea, then amoebiasis. Weight loss with abdominal mass and with temperature, tuberculosis would be a probability. And if there is no temperature, then malignancy could be there. And we have to inquire about the past history of radiation, cardiovascular disease, aortic aneurysm repair. The modalities of diagnosis comes to CT endoscopy. The comparison between CT endoscopy and balloon-assisted endoscopy are the overall detection rates in balloon-assisted are much higher, 90%. Some people say that GI tumors are more properly detected by CT endoscopy, and IBD, angioma, angiodysplasia, and diverticular things are picked up by balloon. This overall CT endoscopy is not good for flat mucosal lesions and vascular abnormalities. And most important, if GI tumors are suspected, then better to add MDCT with device-assisted endoscopy. The approach should be first to do MDCT. The source of bleeding should be located and the correct insertion route should be decided. Now, the capsule endoscopy has come out as the first line investigation. It has got high positive values and the negative values are also high. If the negative values are more important, they almost rule out. Occult bleeding is not that well picked up. Initially, the peel cam came with 2 frames per second pictures, then mirocam, endocam, and capsocam has come. The capsocam is a cheap based thing, and it can be done with pacemakers on, and it has got a 360-degree rotation. It is a OPD procedure. Same thing. This is a picture of peel cam. Advantages of capsule endoscopy that it's non-invasive, it's painless, there is no sedation, traverses whole of SI mucosa, it can diagnose clots or fresh bleeding, it's less costly, and there are less complications. The major complication is retention, 1 to 2%. The main purpose of capsule endoscopy is to find the lesion and to guide the approach, because we can go for antegrade or retrograde endoscopy based on the location. Balloon assisted detects the source of bleeding more. Therapeutic interventions can be done. The working length is around 200 centimeters, but they need sedation. Complications are pancreatitis, bleeding, perforation, and aspiration anemia. Pancreatitis is important. This shows a double balloon endoscope. The one balloon is at the tip of endoscope, and the another is the over the over tube. It is done by push and pull technique. It can do biopsy in elevated formations, ulcerated adenoma, diverticular lesions. For polypectomy can be done, and for angioma angiectasia, APC can be done. Now has come motorized spiral endoscopy, and the comparison are the motorized spiral is faster. It is a single operator test, but it is costlier. Both are equally safe. The depth is achieved both same, and both the diagnostic and therapeutic success rate are same. This is a motorized spiral. There are the spiral pins, as you can note. It goes by spiral process, and there is a processor. This requires standard endoscopic skills. An overall approach to the case of obscure GI bleed management. If there is a brisk massive bleed, first we go for hemodynamic stabilization. If the patient is unstable, then direct angiography should be done and embolization. If the patient gets stable, then the line of thinking should be CT angio followed by angio and followed by embolization. If there is subacute ongoing bleed, then the first investigation would be video capsule. If it is positive, then we have to go for BAE and then treat accordingly. If the video capsule is negative, but or also is positive or also negative with a strong clinical suspicion, we have to go for balloon assisted. If the obstructions or neoplasms are suspected, then CT enteroscopy would be the first choice. If there is occult bleed, then we go for video capsule. If it's negative, then go for CT. Negative, then balloon BAE. If again negative, go for RBC scan, then for angiography, and then for intraoperative enteroscopy. The missed lesions are commonest. Incomplete examination and incomplete preparation, they are the commonest causes. The lesions which are reached with the standard endoscope or colonoscope are Cameron lesions, angioectasias, and hemorrhoids. Varices can be undetected in hypovolemic patients, and blood clots may obscure visualization of the vessel. The lesions behind the mucosal felts also can get missed. And in case of intermittent bleeding like Dulapoi angioectasia, the sites can be missed. There are some blind spots, and if we do a repeat endoscopy, there is 50% chance that we can get to the cause. Now, these are some missed lesions. The first slide shows some erosions, hemorrhagic. Third slide shows the loss of mucosal folds. The fifth slide shows the pyloric antrum. There are some lesions. So we have to be very careful about the posterior part of the stomach, the cardiac end, the antrum end, when you do a hurried endoscope. Approach to the patient of iron deficiency anemia, which forms 10% of G referrals. We diagnose by low serum ferritin and the low iron levels. The sensitivity are quite high. But before jumping into hard things, in case of main and postmenopausal women, we should always evaluate for GI cause of malignancy. In young women, we have to rule out menstrual blood loss. Thank you.
Thank you, sir, for nice and crisp presentation. Now the house is open for question. Any question? Thank you, sir. I think no
thank you.
Thank you so much, sir, for the wonderful session. Now I'd like to request Dr. Kumar Saurabh, sir, to come up on the stage to speak on the topic, Evolving Role of Immunotherapy in GI Cancer.
Everybody, last session of the day, mostly everybody will be very tired. I'll keep the presentation short, crisp. It's an exhaustive topic. Mostly we will be just dealing with
how immunotherapy works. Immunotherapy is something which has recently come into practice in oncology, and it is the new targeted therapy. It is one of the landmark achievements of this decade, and it is so much relevant for oncology that the person who discovered this immunotherapy, the checkpoint inhibitors, they received a Nobel Prize 1 or 2 years back. So this is something of a revolution in the field of oncology. So how does immunotherapies differ from normal chemotherapy or targeted therapies? The basic premise of chemotherapy is that it acts on a rapidly dividing cells. So all the cells which divide rapidly, chemotherapy will act on that. The basic funda of that is in cancer, the cells divide more rapidly than the normal cells. So they are killed preferentially. Targeted therapy, the problem with the chemotherapy was that many times there are a lot of other cells in the body also which have a very high reproductive rate, replicative rate, like hair follicles, bone marrow cells. So chemotherapy was associated with GI lining. So chemotherapy was associated with quite a lot of side effects. People got alopecia, bone marrow suppression, GI toxicity with diarrheas and all. So we needed something which was more specific. Then came the targeted therapy. The early 2000 was a decade where targeted therapies ruled the roost, and they targeted proteins that regulate cell growth, division and spread. And then in the last decade, we got the immune oncology drugs, which are known as immunotherapy. They help the body's own immune system to fight cancer. How do they do that? We'll be discussing in short. So if you see our immune system, the immune system is involved in prevention of cancer that we have known since long. How basically those patients who are immunocompromised, they have a higher tendency to develop cancer. Like for those patients who are suffering from AIDS, they have a higher tendency to develop cancer. So we know that immune system plays a role in cancer. How can we harness that immune system to prevent the growth of cancer is where we did not know at that point of time. So there are two types of responses. One is the anti-tumor response. Generally in a normal individual, these predominate. This is composed of activated and effector T cells, where the cancer basically has a lot of new antigens. Now these new antigens are processed by the antigen processing cells, and these activate the T cells. T cells recognize these antigens as foreign, and the immune system gets activated and they kill off the cancer cells. But cancer is also a very brilliant disease. So it devises mechanisms to escape this immune system. It can do it in a lot of ways. It upregulates the immunosuppressive cells. It upregulates the checkpoint inhibitors, which is basically the PD-L1 and CTLA4. So that checkpoint inhibitors are the mainstay of immunotherapies which we have today. We'll be discussing a bit about checkpoint inhibitors. So these are the checkpoint inhibitors. Why are these checkpoint inhibitors there? So that the immune system doesn't get out of hand. Many times these checkpoint inhibitors keep the immune system in check. But the cancer cells utilize exactly these checkpoints inhibitors to escape invasion. So the two checkpoint inhibitors are, one is the PD-1 and another is the CTLA4. Once these checkpoint inhibitors get activated by cancer cells, the immune system is not able to attack the cancer cell. So generally, the drugs, the modern immunotherapy drugs, they target these checkpoint inhibitors only. So this is, so this is how the immune checkpoint inhibitors, they act as the on switch to reactivate the anti-cancer immune response. So once the PD-L1 inhibitor or the CTLA inhibitor is given to the patient, they block this checkpoint inhibitors, and the immune system gets reactivated once more to kill the cancer cells. So this is the basic this thing. Apart from these checkpoint inhibitors, we have a lot of other immune oncology therapies in process. I'll be discussing in brief 2 to 3. One is the adoptive T cell therapy. Here the tumor is excised from the patient. This tumor will have a lot of tumor infiltrating lymphocytes which will be specific to tumor cells. Now these TILs will be isolated, they will be expanded in vitro, and they will be reinfused in the patients, and these activated T cells will then again kill the tumor which is there in the patient. Another thing is the CAR T cell therapy. I believe most of you would have heard of CAR T cell therapy. It is again it is the most promising cancer treatment which is going to make a lot of changes in the next decade. It is still in experimental stage. In CAR T cell therapy, what we do is that we isolate the T cells from the peripheral blood, and these T cells are modified with chimeric antigen receptor to specifically target the tumor cells, and then these T cells are expanded and reinfused into the patient. So these genetically modified T cells, they recognize the tumor cells specifically, and these things are supposed to be the future of oncology. Apart from that, there are a lot of cancer vaccines also in development. Monoclonal antibodies, non-specific IO therapies, some of them are already in use, like BCG we use in bladder cancer. Now, chemotherapy, we all know the side effects of chemotherapy. Chemotherapies will cause neutropenia leading to fever, chemotherapy may cause mucositis, chemotherapy may cause diarrhea. But with immunotherapies, we have a separate set of adverse events which are different from chemotherapies. So you have to know what side effects these immune therapies may have, so that we can be watchful for that and prevent that when they occur. So these are the immune-mediated adverse events which we generally see, of which most of them are not serious, self-limiting, like hypothyroidism, rash, some sort of anorexia or something. But some of the uveitis, but some of them are seriously dangerous and which will require close monitoring and stoppage of drugs if that develop. That is like colitis, pneumonitis. So these are something which are may seriously even hamper the life of the patient. So okay, now what happens is there are a few other differences also between chemotherapy and immunotherapy. Chemotherapy, it works in a straightforward fashion. You give the drug, the patient develops some side effect within 1 to 2 weeks, and once the drug level falls, the side effects also goes down. But in immunotherapy, it doesn't happen like that. The therapeutic index of immunotherapy is not that well defined as chemotherapy. In fact, the side effects may appear very late during the course of treatment. So this is all related to immune drugs. These are the counseling recommendations. I believe we can skip through this. And again, something regarding dose of immunotherapy. Most of the dosing of immunotherapy are in a flat dose, not like chemotherapies which are done with BSA. In immunotherapies, it is in adult patients, what we do is we give a flat dose irrespective of the weight or height. In pediatric patients, it is based on weight. So, and how do you assess? This is one very fundamental difference between immunotherapy and chemotherapy. In chemotherapy, we use something called as RECIST criteria. So you give 2 to 3 cycles of chemotherapy. After that, you again do a CT scan, and you see whether the disease is responding or not. For that, we have something called as RECIST criteria, and we can see whether the disease is coming down or not. But in immunotherapy, what happens is that initially there is something called as pseudo progression. So after 2 to 3 cycles, if you the problem is the mechanism of action of immunotherapy is that it activates the immune system. So once the immune system gets activated and it starts killing the cancer cells, there will be again a lot of edema and inflammation at the tumor site. So the size of that tumor, now let's say you have a 3 centimeter lesion in the liver from colorectal mets. If you start immunotherapy, maybe after 2 or 3 cycles, that lesion will increase in size. That size will go from 3 centimeters to, let's say, it will become 4 centimeter. But that doesn't mean that therapy is not working. That means that the therapy is working, and if you keep on following the patient, after a few weeks, the size will keep going down, and many times it will disappear altogether if the immunotherapy works better. So this is something called as pseudo progression. But if you see the scans, it will look like the disease is progressing. So this is, for immunotherapy, we have an iRECIST criteria, where even though the disease seems to be progressing, we keep an interval of 4 to 8 weeks and we watch for that. And if the lesions start subsiding, then and we continue with the immunotherapy if the patient is not clinically deteriorating. So if the lesions start subsiding, then we deem that as pseudo progression. So this is something which is specific only for immunotherapy. These are the in fact, in oncology, there are lot of trials going on, and I believe the biggest number of trials, almost 50% of the trials going on in the world will be from oncology. So a lot of new drugs are coming up, and most of the times for any new drug to come into the development, the gold standard for us is overall survival. So whether the drug has made a difference in overall survival or not. But since the cancer treatment has come so much long that most of the patients are surviving for 5 years, 6 years, 7 years, even in stage 4 disease. So overall survival, if we want to prove that a drug is working, then it will take almost 10 to 15 years for a new drug to get launched into the market. So we have got some surrogate endpoints which replace overall survival. They are progression-free survival, time to progression, disease-free survival. So most of the trials in
60, it's a 70 is a Saccharomyces
he was afebrile, he was pale, there was no edema, icterus, clubbing, cyanosis, or lymph node enlargement. He did show signs of minimal acidotic breathing. His bilateral chests were clear. On per abdomen examination, there were 2 mobile cystic swelling that could be palpated, one slightly above the umbilicus and second one in the right iliac fossa. All these routine investigations were sent and ABG was done then and there in the ER, which showed a pH of 7.3. He had a deranged RFT, his urea was around 330 and a creatinine of 18. His hemoglobin was around 6 grams. Iron profile showed anemia of chronic disease. And USG was done, which showed large multiseptated SOL, which was probably hydrated cyst, extending into both iliac fossa and compressing over bilateral lower ureter. Bilateral hydronephrosis were present, and there was right renal clot and organized sludge. An NCCT abdomen was done, which showed multiple well-defined 3.1 to 9.3 centimeter round, sharply marginated, thick-walled, heterogeneous, hypodense cyst in the peritoneal cavity. Thick and thin septations were present within. He had grossly dilated bilateral pelvic calyceal system and both upper ureters were grossly dilated. Our first and foremost task was to manage the patient's deranged RFT and acute symptoms. Injection sodium bicarbonate was given. Injection calcium gluconate was supplemented. Urgent blood transfusions were done. Nephrology and surgery consultations were taken. Several sessions of hemodialysis were done, and after about 11 sessions, his serum creat was around 4. Patient was planned for exploratory laparotomy and excision of cysts. Prognosis of the disease and surgery associated risk factors were explained to the patient and his relatives. Patient was also started on tablet albendazole 400 milligram oral BD preoperatively and was planned to be continued post-op. This case, in fact, highlights the fact that hydatid cyst should be considered as an important differential for abdominal mass, especially in endemic areas. The case also highlights the need for a multidisciplinary approach in managing such patients. Spontaneous rupture of cyst due to thin pericyst is a dreaded complication. The prognosis of disease depends on the extent of peritoneal dissemination, the extent of visceral localization, general condition of the patient, number of surgeries he had undergone, and completeness of cure. Long-term monitoring is essential for determining the recurrence requiring further reoperations. Thank you.
Good evening, respected teachers, senior and my colleague. Myself, Dr. Manish Kumar Sahu, Junior Resident, Department of Medicine. My case is a case of primary biliary cholangitis, diagnostic challenge and management strategy. a case of primary biliary cholangitis, diagnostic challenge and management strategy. Introduction. What is primary biliary cholangitis? Definition is chronic autoimmune liver disease characterized by progressive destruction of intrahepatic bile duct. The cause of PBC is unknown. It is characterized by portal inflammation and necrosis of cholangiocyte in small and medium-sized bile duct. Epidemiology. Affect 1 in 1,000 to 10,000 individual, primarily middle-aged women. Pathophysiology. It mainly depends on two factors, genetic and environmental factor. The development of primary biliary cholangitis is the result of the interaction between genetic predisposition and environmental trigger. Once the genetically susceptible patient is exposed to the aforementioned environmental toxin on bacteria, B cell and T cell response occur. B cell and T cell target antigen that infiltrate the liver and start attacking bile duct cell, leading to the destruction of small interlocular bile duct cell. The destruction of bile duct cell lead to the obstruction of bile drainage from the canaliculi, which result in cholestasis and the destruction of hepatocyte. This cholestatic hepatitis subsequently lead to progressive fibrosis and cirrhosis. Case patient profile: age 48-year-old female, occupation by teacher, chief came with complaint of fatigue over 6 months, pruritus especially at night for 6 months, jaundice for 2 months and abdominal distension and pain abdomen in right upper quadrant for 15 days. Patient was apparently asymptomatic 6 months back, then she started feeling tiredness and progressive fatigueness. After some time she developed itching in whole body, especially at night. For this she took medicine from local medical shop, but itching persists. From last 2 months her husband noticed her eyes turn yellow and later spreading to whole body. From 15 days she developed ascites and pain abdomen over right hypochondrial region. Pain was insidious in nature and relieved by painkiller, but abdominal distension was progressive, so she was admitted in local hospital and from there patient was referred to RIMS. Medical history was patient is hypertensive since last 5 years on irregular medication and hyperlipidemia diagnosis, but not she doesn't took any medicine. No history of diabetes mellitus, thyroid disorder and tuberculosis. Personal history was non-alcoholic, on mixed diet, regular bladder and bowel movement. Physical examination. Patient was alert, conscious, oriented with time, place and person. BP was 152/96 Hg, pulse 88 beat per minute, respiratory rate 18 cycle per minute, pallor was absent, icterus absent, cyanosis absent. Systemic examination. GI system on inspection, abdominal distension present, venous prognosis absent, all quadrant moved equally with respiration. On palpation, no organomegaly present. On percussion, fluid thrill present, shifting dullness absent. On auscultation, bowel sound present, rest of the system was within the normal limit, no abnormality detected. Laboratory test. Liver function test, alkaline phosphatase elevated, GGT elevated, AST is also elevated, ALT is 90 international unit per liter, albumin is 2.5 mg per dl, and coagulation profile also deranged, PT-INR is 1.74. Total bilirubin is 25.84 and direct fraction is 12.70. Autoantibodies, anti-mitochondrial antibody is positive and ANA is also positive. Complete blood count, WBC is 11.7 thousand, hemoglobin 11.2 and platelet count is 1.42 lakh. Imaging study, ultrasound, hepatomegaly, bile duct dilatation, coarse ecotexture of liver, that and liver parenchymal disease. MRCP, intrahepatic and extrahepatic bile duct narrowing. Liver biopsy shows liver cirrhosis with ductular reaction and bile duct lesion. So now my provisional diagnosis is primary biliary cholangitis, biliary obstruction or stricture, primary sclerosing cholangitis, hepatitis, drug-induced liver disease, sarcoidosis, non-alcoholic fatty liver disease, autoimmune hepatitis. Final diagnosis is because of alkaline phosphatase is elevated, presence of anti-mitochondrial antibody, histological evidence of chronic cholestasis, exclusion of other bile duct disease. On the basis of above finding, final diagnosis is primary biliary cholangitis. Treatment: ursodeoxycholic acid 15 mg per kg per day is given. Obeticholic acid 5 mg per kg per day after 3 months because of unresponsive to the ursodeoxycholic acid. patient was advised to obticolic acid. Symptomatic management of pruritic, tab naltrexone and rifampicin is also given. Tab Vislon 40 mg per day in divided dose and subsequently tapered the dose. During follow-up, 3-month post-diagnosis, LFT was alkaline phosphatase still elevated, AST 40, ALT 30. Pruritus improved, fatigue persistent. Continued UDCPA and vitamin D supplementation is also given. 6-month post-diagnosis, alkaline phosphatase is still elevated, AST 30, ALT 25. Pruritus resolved, fatigue improved. Continued UDCA and vitamin D and added obticolic acid for inadequate response to UDCA. Thank you.
Good evening everyone. My topic is a case of DAC in acute pancreatitis presenting as ischemic stroke. Now case presentation, 54-year-old male in emergency presented with complaint of pain, abdomen and fever for last 7 days. Sudden onset of blackish discoloration of fingers of upper limb and water sensitive for last 3 days. There was a history of binge alcohol drinking prior to pain abdomen for which he was given IV analgesics. There was a history of chronic alcohol intake for more than 25 years. No history of trauma, no history of diabetes mellitus, hypertension, pulmonary TB and smoking. On examination, patient is disoriented with GCS of 9, febrile to touch, BP was 100 by 60 mm of Hg, pulse rate 89 beat per minute, respiratory rate 20 per minute. On local examination, distal swellings of middle and ring finger of both hands were gangrenous. On systemic examination, CVS examination, S1 S2 heard, no murmur was present. On respiratory examination, bilateral air entry present and clear. On CNS examination, spasticity of was present in right upper and lower limb, and plantar was extensor on right limb. Ankle, knee, biceps and triceps reflex were exaggerated on the right side of the body, and normal findings was present on left side of the left upper and lower limb. On lab investigation, CBC examination, hemoglobin was 12, TLC 18,000, platelet count 83,000, serum creatinine 2.4, and blood urea nitrogen was 22. CRP was raised, lipase, serum lipase was 345, lipid profile, serum triglyceride 130 and cholesterol 100. Ultrasound abdomen shows bulky pancreas. EQ and ECG was within normal limit. PT 18 second, D-dimer 2.5 and FDP was raised more than 5 times of the upper normal limit. Serum fibrinogen was 0.9 gram per liter. MRI brain shows multiple small infarct on left side of frontal, parietal, temporal and occipital regions. Diagnosis, disseminated intravascular coagulation in acute pancreatitis presenting as acute ischemic stroke. The patient was managed on the lines of DIC with acute pancreatitis with early and aggressive fluid resuscitation, blood products like FFP. Patient was kept NPO at that time, and vitamin K, IV analgesic and antibiotics was given. Now discussion. Acute pancreatitis have systemic, local and vascular complication as we know. Fluid sequestration in patients with acute pancreatitis in first 48 hours is significantly associated with SIRS criteria and the subsequent development of multi-organ failure. DIC is defined as acquired syndrome characterized by intravascular activation of coagulation with loss of localization arising from different causes that can originate from and cause damage to microvasculature, which if sufficiently severe can produce organ dysfunction. Activation of inflammatory pathways in response to infectious pathogen results in increased expression of tissue factor. activation of neutrophil and monocyte with the release of cytokines and development of neutrophil, extracellular traps, and release of polyphosphates that engage in crosstalk with the coagulation system to cause thrombin generation. This process is known as thromboinflammation. The common mechanism of cerebral infarction in acute pancreatitis is fat embolism, while cerebral infarction from arterial or venous thrombosis is a very rare complication of acute pancreatitis. Now concluding, as ISTH score was calculated on the above readings was 6, that means over DIC. SIRS score was 3, so it was suggestive of overt DIC. So the cause of hypercoagulation was DIC in acute pancreatitis. Therefore, DIC required a strict management to prevent such deadly complications. Cardiac cause of embolization was ruled out by echocardiography, that was normal. Temporal association of acute cerebral events suggest it is directly related to acute pancreatitis, as there was no evidence of fat embolism was seen. Vascular thrombosis and cerebral infarction are a very rare complication of acute pancreatitis. Therefore, treating physicians should be aware of vascular, thrombotic, and neurological complication of acute pancreatitis to prevent further morbidity. Thank you.
Good evening, everybody. So this is the last case presentation. The topic is an autoimmune crossfire, unraveling a case of chronic liver disease of autoimmune origin and myasthenia gravis. So the patient, a 22-year-old male, presented in the emergency with the chief complaint of abdominal distension since the last 6 months, constipation since the last 3 days, and being in altered sensorium since the last 2 days. Since the patient was in altered sensorium, we couldn't take history from the patient. Informer, being the father of the patient, gave history of abdominal distension since 6 months, which was symmetrical and gradually progressive. He also complained of constipation since the last 3 days. However, patient was passing flatus. The informer also complained of the patient being in altered sensorium since the last 2 days. No history of fever, cough and hemoptysis, no history of alcohol or any drug intake, no history of weakness, slurring of speech, no history of weight loss, no history of palpitations and shortness of breath, no history of pain abdomen. Patient was admitted with similar complaints at local center, for which he was taking torsemide, pantoprazole since the last 2 months. However, no documentation was available. We could only retrieve the medications available from the patient. Patient was also taking Ayurvedic medications for the same since the last 1 month. The patient was also taking levofloxacin and tinidazole since 3 days for loose motions on suggestion of a pharmaceutical shop individual. No history of hypertension, diabetes mellitus, thyroid disorder. He is a non-smoker and a non-vegetarian. On examination, patient is disoriented to time, place and person, BP being 90 by 68 mm of Hg, pulse rate being 112 per minute. On per abdominal examination, shifting dullness was present, splenomegaly being present. CVS and chest findings were within normal limits. Coming to the investigations, patient's hemoglobin was 9.2, MCV being 92, and WBC being 12,800 cells per cubic mm. Total bilirubin of the patient was 4.6, indirect fraction being 0.8 and direct fraction being 3.8. SGOT 178, SGPT 202, and alkaline phosphatase being 142. The total protein of the patient was 8 mg, serum albumin 3.1 and serum globulin 4.9. The PT of the patient was 27.4, INR being 2.42. RFT, serum electrolytes, urine routine examinations were within normal limits. The patient was advised lactulose enema. Symptoms of the patient started improving. However, patient was unable to open his eyes completely in spite of improvement in the sensorium of the patient, which prompted further evaluation of the same. A bedside ice-pack test was done, which improved the ptosis of the patient, and a provisional diagnosis of myasthenia was considered. This is the image of before and after the ice-pack test. As you can see in the first image, the patient has ptosis, and the ISPAC test was done for 60 seconds. Post that, when we removed it, the ptosis of the patient improved. The day 2 findings: ultrasound was suggestive of cirrhosis of liver with portal hypertension, splenomegaly, and splenic granuloma was seen. Portal vein being 15 mm, ascitic fluid suggestive of SAG of 2.4, upper GI endoscopy suggestive of multiple esophageal varices of grade 3. Anti-smooth muscle antibody was positive in this patient. Serum IgG being 11,445.7 and acetylcholine receptor antibody was positive. Diagnosis: based on the above clinical, biochemical and other laboratory findings, a diagnosis of chronic liver disease of autoimmune origin with myasthenia gravis was made. What is the criteria for diagnosis? In this particular case, after using the criteria, the patient was diagnosed with chronic liver disease along with myasthenia gravis. Patient was started on tablet prednisolone 20 mg daily, followed by an increase in the dose by 5 mg over 2 to 3 days till a steady dose of 40 mg once daily. Tablet pyridostigmine for myasthenia 60 mg thrice daily. Tablet calcium once daily and tablet pantoprazole once daily. Autoimmune hepatitis is a disease of unknown cause that is characterized by the presence of autoantibodies, hypergammaglobulinemia, and lymphocytic infiltration. Coming to myasthenia gravis, it is an immune disease in which circulating antibodies against components of the motor postsynaptic membrane and subsequent structural changes in that membrane explains virtually all the features of the disease. In our particular case, the overlap presents as a challenge as myasthenia in the patient limits the usage of drugs. The use of fluoroquinolone in this particular patient precipitated and eventually worsened the symptoms of the patient. A cautious use of medications is thereby indicated in such patients. Follow-up: patient was discharged on medications with monthly follow-up basis on tablet pyridostigmine being 60 mg thrice daily, tablet prednisolone 20 mg once daily, tablet calcium once daily, tablet pantoprazole once daily, and tablet spironolactone 25 mg once daily. Thank you so much.
One changes in quiz. Dr. Nanak Laha will share his prize with Mayank because both have got 11 marks. This happens because of some technical issue.
कोई कंपनी नहीं है साथ चला गया बारिश बहुत हो रहा है चलिए